All right. Hey, everyone. Good morning. Sorry, I'm a bit late. I am just kind of shuffling between technicals and communication and admin work. So it's a chaos. Anyways, if you have any question for me, from what we discussed yesterday, I'm happy to answer. So you've got a bit of time. Any questions so far?
Nazia, so in uncontrolled diabetes case in orange set,
Uh-huh.
the pulp extirpation that we're doing, do we still consider that because we're not removing the source of infection? Do we still give phenoxymethyl penicillin after that?
Okay. So why would you think that you're not removing the source? What is the source?
I mean, the nurse could be the source, but then I'm thinking the tooth is still there.
Yes, the truth is there. Now, see, again, we're talking about the biases, right? So let me just that's a very good question. And look, any question that doesn't make sense, please ask. It's good to have discussion about. Let me share my screen. Now, I'll go back to the first thing. When we decided to remove this tooth, the decision was based on the fact that it was a badly broken tooth. It was never about spreading infection to begin with. Do you see in the scenario it says grossly decayed?
Yep.
So that decision was to begin with grossly decayed. You know that with pulp extirpation, we do even periodontal debridement with spreading infection. That's TG, right? TG says that if somebody comes with spreading infection, go back and check the source. If it's coming from the gum, do periodontal debridement, give them antibiotic. If it's coming from the tooth, if the tooth is restorable, go with first stage of root canal treatment and then continue. If it's non-restorable, extract. Now, our tooth was non-restorable, but it doesn't mean you can't do pulp extirpation because there was nothing wrong with the roots. So when you do pulp extirpation, that was another question one of the examiners they asked. You can't leave it empty. You don't leave it hollow. Remember, you put odontopast inside it, which has antibiotic. What is the ingredient of odontopast? It has antibiotics, right? Yeah. So now, whether this patient takes antibiotic as a tablet, whether you put it inside the tooth, antibiotic is an antibiotic. Antibiotic will kill the bacteria where they are. So we know that there will be bacteria here. So we've placed an antibiotic inside the tooth. And additionally, we're giving this patient amoxicillin or phenoxymethyl. Phenoxymethyl when you give. So two antibiotics, one that is locally, one is that's going to be killing the bacteria that are in the facial spaces. Done. You've done a good job. Why wouldn't it work? Does it make sense?
It does, but the only thing that I'm thinking is because it's a badly broken tooth and we don't even know we would be able to do a complete debridement, and also there is spreading infection. I don't know. It could be the previous thing that we used to give metronidazole and like, don't give metronidazole. Like, oh, is it enough?
Yeah. So again, that's our previous learning. See, in a fast-paced world that we're going, the biggest asset is unlearning and relearning.
Yeah, that's right.
That's me always, unlearning and relearning, moving on fast, right? If it doesn't align with your thought process, with the guideline, chuck it away. Never clung to it. So just going back to the ADA, when we do the billing, you see, there's two categories of billing. In fact, Dr. Madhya was telling me that she'll do a session for billing. A lot of dentists, after passing exam, they don't know how to bill. So it says incomplete endodontic therapy, tooth was not suitable for further treatment. This is the one that we're going to bill the patient. It's not suitable for further treatment. I'm just going to do it today, temporize it, right? And then there's another category, extirpation of pulp, because you want to save this tooth. Both are extirpating the pulp, but one where I cannot save, different code. One that I'm planning to save, different code. Does it make sense?
Yes. So we'll say just remove the nerves as much as possible to get rid of the source of infection as much as possible. We'll be putting antibiotics and additionally giving you another antibiotic.
Yes. Look
Yeah.
again, I'm just going back to this is something they've done. Like I've given that example of Dr. Usman that we have, first day in his first after passed his exam in a clinic, he said and his patient couldn't even swallow. That's how bad it was with spreading infection. And he did pulp extirpation. He was like, I was surprised when the patient came back after 2 days, gone, all gone. Right? So it works amazing. So acute odontogenic infection, this is what they are checking us. You see how uncomfortable it is talking about it. So here they say, so we need to do a dental procedure. Even with the pus, they said, you can collect if feasible, but we're not expecting any pus to come oozing out, whether you extract, whether you do pulp extraction. We don't expect because in cellulitis, there's no localized collection of pus. So they said dental procedure, either you extract or you do endodontic, right? Or we do periodontal treatment. Any one of them, or surge extraction, address the source. We are doing that. So we do emergency pulp extirpation, we place odonto paste, we've addressed the source. Additionally, that bacteria that is on the face, we've given phenoxymethylpenicillin. Done. We've followed exactly TG.
Yes. Nazia, sorry, one more question. It's already 10 yet. You can answer it later also. But then for the MIH case, so sorry, yeah, yeah.
No, no,
So,
go on.
yeah, so the MIH case, so if we want to manage the sensitivity today, what are we doing?
So it's that 11-year-old boy that we're talking about?
Yes, yes. Nick.
Okay. Now, the first thing we need to understand why this boy has sensitivity. Sensitivity is a sign that there is an active decay going on. Okay? And now, if there is an active decay going on, I'll just go back to this flow chart here. I think it was given beautifully in DHSV. Yes. So DHSV says now, one option is we go with a permanent filling, which is composite, or the other option is we go with temporary. Now, I don't want to go anything permanent on this tooth at this point. It's not easy to use a composite on that tooth. It can be done. So what we're doing here is we're going with GIC. So there was a cavity. You couldn't see it on the buccal side, but on the X-ray you could see it. I'll show you on the X-ray here.
Okay, so in exam, on the X-ray, we can see the cavity because in my head, I don't see any active decay, and I don't know if I'd be offering varnish. That's why I was thinking.
That's a very good question. Let me just go back to this. So they say that I think sensitivity, I'll go back to this line from DHSV. Where was that line that it spoke about when a patient is having sensitivity, it's a sign that there is active caries going on. Yeah, sensitivity. So hypomineralized molars are fragile and there's increased protein and decreased mineral content, making them soft and porous, susceptible to post-eruption breakdown. Caries development is aggravated. You see, is aggravated by the sensitivity of these teeth. Now remember, this patient sensitivity got worse. The child wasn't brushing properly. So if you put a fluoride varnish may reduce the sensitivity to a certain extent, but what if by now there, because of the post-eruption breakdown, we have plaque stagnation areas? What are you going to do about that? Right? So that's why it says in that flow chart that DHSV has given, you have to see as long as there is no post-eruption breakdown and there's no caries. Now, sensitivity happens when something has reached the dentine. Would we have any? This is a part one question. If you have a lesion in enamel, there was a question. What would a patient experience? Nothing, right? Sensitivity happens when something has reached the dentine because dentine communicates with the pulp. So now we are in that stage where there is either a caries or post-eruption breakdown. So in that case, go with GIC, temporary. Clear?
Okay, all right. Should we also be so putting a cap on the tooth? Is it more like in the long term?
Now
Like
there were 40 that had problem, right? Or
yes.
this case is about ortho, and this was more about this child would need an orthodontic treatment because of malocclusion. So if there was a class 2 skeletal discrepancy, then we would remove the upper molar. So in this patient, maybe the upper molars will be removed. and the lower ones that will be kept, yes, those are the ones that possibly a pediatric dentist might place a cap.
Yes, but for the follow-ups should be offered because Nick is that the tooth is so if the tooth is removed, but still there is this incisors. So for the follow-up, what are we doing? Like the preventive advice?
Your job is to make sure that the child is cleaning, brushing properly. Now,
Mm.
remember, MIH is not your scope of practice, like the active treatment. Your job is maintenance. All right.
Mm-hmm.
So, if we go into DHSV as well, referral section, it's clearly mentioned. So, where is that referral section here? So, if I go into a specialist, so for the front teeth, we can do it. Sorry, just a moment. All right, sorry about that. So I'm just working around all different areas today. So going back here, so pediatric dentistry. If I go into the specialist pediatric section, referral. So do you see on the top they say complex dental pathology requiring specialist management, MIH. So for the active part of the treatment, where to make a decision which tooth is coming out, to place a metal cap, to improve the aesthetic, specialist. Okay, because it's hard to numb those teeth. Now, the maintenance part is your job. So your job is to put fluoride varnishes on a regular basis, either twice a year or 4 times a year. Your job is to reinforce oral hygiene habits. That's what you're going to be doing.
All right.
All right.
Yeah. Thank you so much, Nasia.
No worries. All right. Let's get started with the remaining cases for today. So we have got interstate patient, ulcer on the tongue. And we have consent for extraction, cluster 3. Does anybody would like to start?
Can I do the ulcer case, doctor?
Let's do that. Yeah. Which version should we do? Okay, let's do the easy version. Now, cluster 1 again. Remember, it's revolving around health promotion. These are not real patients. We are pretending to be a patient. You're pretending to be a dentist. I'm pretending to be a patient. And there is a message that needs to come out of these OSCEs. So cluster 1, I'm checking your data gathering skill, which is very important. Because when they come with these problems, we need to understand the circumstances, what led to it. So, which is our data gathering. And then you need to list down what you're suspecting provisionals, the risk factors that might have led to this, examination, clinical, pathology, diagnostic, radiographs, and then a bit of patient management. I know it's a lot of list, but just the important stuff that we talk about, right? So from each category, we talk about important examination. You can't go through everything. From every category, we're talking about one thing that is important. So that's okay. Let's give it a go. 3 minutes. Here we are. All right, so if you're ready, and here we go.
Hi, Mr. Cooper. I
Um,
understand. I
yes,
under,
hi, doctor.
I understand you are worried about the ulcer on the lateral side of the tongue. May I ask you a few questions and then I will examine your mouth and we can see what we have to do today?
Yeah, for sure. Look, I'm not concerned as such. It's just that I was due for a checkup, and I thought now that I'm here, I would ask you question, to see if you can check this sore spot that I have for a month now. It doesn't bother me, to be honest. I mean, sometimes mild discomfort here and there, but I just wanted you to have a look.
Okay. Can you describe me what you noticed in the first, when you noticed this
Uh,
ulcer on the mouth? Can you describe it for me?
Describe what?
The ulcer. What did you notice in the first?
This is what I noticed. What you see, I noticed it about a month ago.
Okay. Is the ulcer painful or sore or burning?
Yeah, like I mentioned, doctor, it just causes mild discomfort occasionally. Let's say if I have something very spicy or acidic. Otherwise, it doesn't trouble me, which is why, I didn't come earlier. It wasn't bothering me as such.
Okay. Had you have ulcer like this before, or this is the first time?
Oh, never had it before. No, this is the first time that I've had it.
Do you notice like any change in the ulcer, like in the shape, in the size, or anything?
Look, doctor, I've got a very busy life. I wouldn't be sitting there watching my ulcer. I've no idea. It's at the back of my mouth.
Okay. Do you have like any fever or illness?
No, I don't have any fever. But doctor, is this something that I should be concerned about?
No, but we have like to take this seriously because this ulcer lasts for a month. That's why we have to check it properly. And I would like to ask you more question. Do you have any ulcer like anywhere in your body or any other way in your mouth?
No, not that I've seen. No, not at all.
Do you have any swelling in the face or the neck?
No, I don't. Now,
Any,
why would you be asking me this question, doctor?
because the long-standing ulcer may cause some swelling in the lymph node below the neck and the jaw. That's why we have to check it. Um, any like difficulty in moving the tongue or swallowing or pain during swallowing?
No, I think that's fairly good. Said doctor, I don't no problem other than occasional mild discomfort, no issue with swallowing or anything else.
Okay. Is there anything like elevate the pain, like spicy food or like acidic drink or rubbing against the tongue?
Um, yes, I think now that you said yes, I've sharp tooth on that side. When my tongue rubs against it as well, sometimes it causes discomfort.
Do you feel like there is any sharp edge in the tooth or
Yeah, I mean, there's something feels sharp to my tongue.
this could be like a possibility cause a traumatic ulcer when you rub your tongue against sharp edge in any teeth? Can you tell me if you have any medical condition,
No, I'm good. I'm fit and healthy.
any allergy?
No, I'm not allergic to anything.
Do you smoke or drink alcohol?
Sorry, could you please repeat it?
Do you smoke or drink alcohol?
Yes, I like to have red wine every day.
What
They say
about
it's quite healthy.
smoking?
Smoking, no.
Okay. I will examine your mouth. First of thing, I will examine outside your mouth to see if there is any swelling in the jaw or the neck. And then I will
Why
examine,
would you be checking that, doctor? I mean, I don't have any problems in those areas.
yeah. I know. We have to check if there is any swelling in the jaw because the long-last ulcer, it could be cause any swelling on the lymph node. That's why just we have to be sure if there is any like swelling there, and uh, we have to do some examination inside your mouth. Like I have to check the ulcer. It is firm or hard, the shape, the size, any abnormality.
So
Uh,
should I be worried about this, doctor? I mean, is this something concerning?
um, it's not like that, but we have to take it seriously because it's on the lateral side of the tongue, and it has been like for a month. I would like to refer you also to the specialist to do some investigation like biopsy.
Why would I go to a specialist?
Because I'm worried it could be a cancer. It could be, but we have to do the biopsy with the specialist. Or we can, if there is any like sharpness in the teeth, we have to smooth any sharpness and review
Yeah.
1 to 2 weeks.
But look, doctor, I don't want to go and see a specialist. I mean, is it something that we could hold it because I've got a couple of things lined up?
Yeah, I highly recommend it to go just to uh, because the early assessment it will be good. It will be good, and if you don't like to go immediately, we can smooth any sharpness, and I will give you some gel to put on the ulcer, and you have to keep your mouth clean and avoid any spicy food or acidic drink or any hot. And you can like rinse your mouth with salt water many times in the day, and then we'll check you in 1 to 2 weeks. If the ulcer is still there, you have to go to the specialist to do the biopsy and confirm if there is any things we have to do it.
Okay. So, doctor, I mean, so which specialist are you referring me to, and what are they going to be doing?
For oral medicine specialist or maxillofacial, they will have to take a small piece of the ulcer and examine it under the microscope.
What is that? Is this a special test?
Biopsy, cold biopsy.
Oh, my friend got a biopsy done and she had cancer. Is this cancer, doctor?
It's not, we can't say that, but we have just to take it seriously and check if
So,
they,
but it seems to be cancer. You said take it seriously. Am I dying?
no, it's not like that, but we have to, to be sure and take care of that.
Okay, but so they're going to do a biopsy. Now, what are you doing today for me, and what is the most likely cause?
Yeah. The most likely cause could be traumatic ulcer because you have sharp edge in your teeth. That's why we have to smooth this area first of things. And I will do some investigation, check everything in your mouth. And then I will refer you for the specialist.
Okay, all right.
Do you have
And what else?
any questions? You want?
Anything else you would like to add?
Uh, Yes, just like avoid any acid food, avoid rubbing your tongue against the tooth, and we have to refer you also to the GP to see if there is any vitamin deficiency because also it could be
Vitamin deficiency. What? Which vitamin deficiency?
iron, vitamin B12, or zinc. If there is any deficiency in this vitamin, could cause
Okay.
could be
What else?
And I want to ask you, like, are you stressed this recently? Are you stressed recently?
Well, look, I mean, I am a teacher, of course, that comes with a lot of responsibility.
Yeah. That could be cause also ulcer. We call it like after ulcer.
Okay. All right, great. Sorry, so it was your voice was breaking, but no, thank you so much for doing the role play. And that's why I was just asking you questions. Sometimes your voice was breaking. I don't know if it's my internet or yours. But great. How do we go?
I feel I missed some gathering information about like if there is any recent trauma.
Yes.
Very,
And how we would have asked that question.
yeah.
What do you think? So it's a
Um,
question that we should be asking, right? So remember, yesterday I said swelling, ulcer cases, always make sure you ask them
mm, yeah.
what is their idea. Can they recall any event like yesterday when we did a periodontal access?
Mm,
Because that question was not asked. I never said about the food,
yeah.
right? And today in this case, I'll say, all right, well, Mrs. Cooper, now that you said you've had it for almost a month, do you remember like how it all started? Can you recall anything that might have led to this? Right? So that's an open-ended question. Now, the version that I was doing, mostly that the examiners, they say, well, I don't know, it just appeared. Like this version that I was doing, I accidentally bit on my tongue. This also comes in the exam, along with sharp tooth. Sharp tooth is there for sure, all versions. But additionally, whether I bit onto my tongue, whether I had a sharp crust toasted bread, eat any one of those. So it's important to find out from this patient, okay? Now, what is this case built on? So this is a case built on lung cancer. But I wasn't smirking, isn't it? Now, was it really that this patient was not smirking? Would you believe me on that?
Mm,
Right?
okay. Maybe vaping. I have to ask about vaping.
You have to ask exactly. Now, what happens here is when you ask, one question is, do you currently smirk? This is from your therapeutic guidelines, right? I said no, which is a version rarely comes. This is like a less common version that comes. But when it did, I remember this entire batch that was struggling. They were like, my goodness, the examiner was not smirking. Have you smirked in the past? Right? Now, this is should be always if they or any especially in these cases, if they say no, double check. Have you so are you currently smoking? Do you smoke? Patient says no. Okay. Well, that's great. And but have you ever smoked in the past? Now, this is where I would have said, yes, I used to smoke. I just recently quit. And the next question would be, that's amazing. Congratulations, sir. What was the motivation behind that? And for me, it was my smoker's cuff, right? So what happens is that when people they quit smoking, or whether they smoke, the damage that is done is done. You can't really reverse it, and especially any impact on the lungs, it takes 15 years to go away. The risk of lung cancer only goes down after 15 years. So where is that area? I have this slide, quitting smoking. There is a very good flowchart where it talks about the benefits. Yep, here. I think it's this one. The risk of dying from lung cancer is about half that of a person who's still smoking, even 10 years after they quit smoking. Do you see that? So, in this case, in the exam, what we're potentially dealing with is a lung cancer. Now, inside the mouth, yes, this can be a traumatic ulcer, or they give you a photo like this. This can be a squamous cell carcinoma. Sometimes patient can have two different types of cancers as well. So you have to see, and it is possible that I came because of a traumatic ulcer. Look at the white halo around it. It does look like traumatic ulcer to me, but it doesn't mean that I I don't have ulcer in other parts of my body. So in this case, cuff is an extremely important assessment question that you need to ask. All right. So I'll show you how to go about. So who is this patient? What's going on? So this is basically about a patient that is a teacher. And I'm telling you, this is the good story. I did ask a couple of people again. I said, is she still working in the school? They said yes. So she's still working there, going strong, or he. And you know that in Australia, teaching is one of the most stressful jobs, especially in schools. It's a really underpaid job with a lot of responsibilities. And what was happening with this patient was now also as we get older, you know that cancer risk goes higher with age. And now she's 55. With a lot of stress, what happens is that then the sleep goes away. The diet might not be best. Now, uh, she might be smoking. She might be drinking alcohol for years and years. Why now? Now it's your immune system that was protecting. And when at this age now that she might be experiencing a lot of stress lately, the immune system is no longer protecting because she's not eating well or he's not eating well. Diet is extremely important. So one of the major treatment for lung cancer is immunotherapy. So what do? They boost the patient's immune cells. They make the patient's cells fight back the cancer. If your immune system is well, cancer will not happen. So that's the issue. So then, I cannot take the stress, the situation in her life away from what I'm looking inside the mouth. It's a very important part of this case. With cancer patients, relapse is very high unless we go back to the main causes. So if you want to give me advice about quitting smoking, reducing alcohol, we need to tap into that main cause. So going back, in this case, so how should we go as you started? Remember, this patient came for a check. So introduction was good. If you've done the examination, no need to introduce. If you haven't, then introduce yourself. It's a cluster 1. So it's all right. Jane, so you're here today for checkup, and you were mentioning earlier about having a sore spot on your tongue. So how about we look at your concerns first. I'll be asking you some questions, and then we can discuss about how we can manage it. So with this, when you tell the patient you'll be asking questions, you're giving them a heads up what's coming. Also, when you're writing things down, remember when you are writing, take consent. So I'll say also, would it be okay if I write down as we speak? It's just for my own record purposes. So I'm just basically taking a verbal consent. I don't want them to look at me as somebody mysterious writing, scribbling. Patient says, okay, all right. Sorry. So tell me more. Now she says, well, nothing much, doctor. I just was here for a checkup and I had this sore spot here. And it's been there for a month. Now I did give a bit of Socrate. I said, it's been there for a month. I gave sight. So when the patient tells you, hear it. Sometimes it's easy for us to forget. But when you ask, let them know that, well, earlier you mentioned that, you've had this sore spot. Sorry, I'm just wanted to confirm once more. How long has it been there? So let them know I've heard it, but it just didn't register. Rather than just throwing a question on the examiner, they're like, okay, they're not listening. It's a very important area. Sight. So I said, it's been there for a month. And I said, it doesn't cause a lot of pain. I gave pain scale. Said it's only occasionally when I take something spicy and acidic. So I gave exacerbating as well. You see, so I gave sight, exacerbating, and I gave a bit of pain scale. So as I was giving you answers, I was calculating how much information I should give. Now, between any 3 of them, you pick one and ask a question. So we say, all right. So when you say spicy food makes it causes discomfort, it causes discomfort. What else? Okay, I'll go the exacerbating route. So I'll say, well, I think something very my tongue is also when my tooth rubs against my tongue. I've got a sharp tooth. It causes discomfort. Sometimes when you say more, they will tell you about sharp tooth, or sometimes they say, "Oh, that's it," and I'm holding the sharp tooth to myself. Okay, so I know there's a sharp tooth, so I'll say, "Okay, that's okay." Now, you remember you said it's been almost a month. remember how it all started? Like do you remember if there was any injury or anything in that area that is irritating? You see, I'm going back. Tell me, buddy, what's causing this? And patient says, oh, I bit on my tongue. This is the version I was doing. Okay. And so do you feel like it? So you bit onto the tongue. So are you aware if you grind your teeth? No, I don't. Right. Okay. And have you had these ulcers in the past? Now I'm going back into the grinding. If they're grinding, did they had a history of that? Patient says, no, I never had it before. That was my teeth. Okay. So time frequency. I said, no, I never had it before. Now at 55, if she never had it before, don't even bring afters. Afters, first episode 55 never happens. Afters only happens, it's a recurrent ulcer. It can happen at 55 years only if they had a past history. So, which is another version that comes in the exam. But mostly, if they say, no, this is first episode, don't even bring that. So we say, okay. Now, you also, so have you noticed like when you're talking, when you're speaking, or when your tongue is moving, do you feel like any tooth that feels sharp on that side? Right? So think about the anatomy here. So when a patient talks, when the patient, sorry, just a moment. So here, now we have to ask the patient that, okay, so have you noticed when you talk, remember she's a teacher? So being a teacher, she's talking, and that's where I'm going to go into the coughing history. This is my plan A. So we say, when you talk, do you feel like your tongue rubs against your teeth in that area? Patient says, oh yeah, I remember there's a sharp tooth. They will not give you a sharp tooth in this case. They hold it back. So I'm just going to give you which questions they will hold it back. And you need to have plan A and B and C for those ones. And which ones they will give away easily. So sharp tooth, they're not going to give it easily to you. Now, the next thing then you need to ask, I'll say, okay, now that you said that it's been difficult for you to, it causes some discomfort. So how's your diet been lately? Do you see, I'm going to jump here. There is some questions, but it's okay. I can come back to it. But diet is very important because remember we said cancer happens to those patients that immune systems are down, those that are not eating well. So patient says, yeah, that is okay. I mean, I try to eat, whatever comes my way. Okay. Because you mentioned you're a teacher. So, and how do you kind of balance things to, work life? And patient says, oh, it's very stressful. So, okay, I got very important another history from a patient. I didn't ask the patient, are you stressed? Because many OSCEs now, when we're going directly for stress, they're like, no, I'm not stressed. Everybody's stressed. So differently. So how's, being a teacher, do you find your work quite demanding? Do you find, do you get time for yourself? This is my plan B to find out about stress. Patient says, no, I work long hours. I make up. This is what the exam said. I make up for my friends as well. I do their work as well. So we say, okay, and what do you do about it? When you have those long days and when you get stressed, what do you do? Now I'm getting into smoking and alcohol because these two are very important for me. So one way is you say, do you smoke? Do you drink? Or we say, what do you do when you get stressed? I say, I smoke and I drink. Right? I'll tell myself. And then when they say smoking, then we ask them, okay, so with smoking, would it be okay? Like if I ask you how long have you been smoking? Now we need to know the duration, amount. Okay. Have they ever tried quitting? So with smoking, 4 questions always. Duration, amount, reason for smoking, which I have already given. My reason was stress. And the 4th one is, have they ever tried quitting smoking? If they did, why it didn't work? Okay, so that these are 4 standard questions. We can move them here and there, but these are the standard questions. If they say, no, I don't smoke, then the question is, did you smoke in the past? Okay, but if they say yes, then you ask these 4 questions. Make sure you write it down. These are very, because they will not give you these informations easily. So I said, well, I do smoke. I smoke about 10 cigarettes per day. And I've been smoking for 25 years. Most of the versions that they come in the exam. Now, the one that I was doing, I quit smoking. So if you ask, do you smoke? No, I don't smoke. So were you smoking previously? Yes, I did. I quit recently. Oh, that's amazing. And what was the reason behind, quitting smoking? Such a big decision. Patient said, "Oh, I just had, smoker's cough." Oh, smoker's cough. Okay. And have you seen your doctor as well about it? Have you had your general check done? No, I haven't done it. I just find it's going to get better. Okay. Well, have you noticed any weight loss lately? Because those that have lung cancer, they would have weight loss as well. Again, it could be a late feature. This patient never had weight loss, but I always double check. Patient says no. Okay. Well, maybe this could be a good idea as well to check with your doctor, making sure that, your general health is well. You can talk about it now as well if you think it's relevant, or you can talk about it later. So we need a blood test and we need a chest x-ray for this patient. These two are extremely important. One of the girls, she failed this case and lost the entire cluster 1 in the exam. And she told me, but I said everything. And I said, yes, you did, but you did not address the lung cancer. And if this patient dies, you're responsible for that. Right? So remember, we care so much about the teeth, but these becomes important if the patient is alive. So it's very, very important. So then we say, all right, now plan A is we go smoking. When they say, I've recently quit. Why? Because I have a smoker. The other way to get to the cuff is, do you smoke? Patient says yes. So how many cigarettes? Patient says about 10. Then I'll ask, has there been any changes in the amount that you've been taking? And patient says, yes, I've reduced it recently. Why? Cuff. That's my plan B. Reduce. Third one is, when you mentioned that it's sore sometimes. So when your tongue rubs against your teeth when you're talking, or do you have any kind of chest infection? Do you cough? So I'll go through that irritation route. So these are three ways we'll get into this cough. Very important. This is the major assessment area in this case. That's why they don't give you very easily. Fourth, I will cough. And I did cough in the 9th minute, which I don't think so you observe, but I would cough. Either they will cough in the first 3 minutes or they will cough in the last 1 minute, or they won't cough at all. So then we say, all right, now, Jane, so just now, thank you for providing me all these information. And I think I might have a better understanding as to why you might be having this source. Would you like me to explain it to you? Patient says, okay. Then we say, all right. Now, one of the most commonest cause of seeing these ulcers inside our mouth is because of trauma. We call them as traumatic ulcer. You see, straight after history, I went into provisional because I need consent for investigation. So go provisional, then investigation. So we say, now you mentioned that this ulcer was not there. It was only when you had a sharp tooth, and when your tongue is rubbing against it and you bit onto your tongue as well. That might have initiated this. And lately, since your diet hasn't been best, if your immune system is not functioning really well, the healing might be delayed as well. So that's one possibility. The second possibility, sometimes it can be concerning as well. Now, why am I saying that is because where this ulcer sits, we call them as a high risk areas inside a mouth. So, as I can see, it's on the side of your tongue. It's been for more than a month, and it's not very painful as well. So, you mentioned also that you drink and you smoke. Now, do you have any idea how smoking and alcohol affects? Patient says no. Okay, so when you smoke and when you drink, what happens is those chemicals that are present, they pool on the floor of your mouth. And the longer it stays in contact with your skin around these areas, the more damage it does. And sometimes it can cause abnormal growth. Now, patient, this is also a very important question they ask. Is this cancer? Right? So you've got to be honest with this patient. If they say, look, go back to the photo. You see, this doesn't look like cancer. Right? So we say, well, look, Mrs. Cooper, well, looking at the appearance, I mean, it doesn't seem to be like a cancer, given that it's got this white shadow and you've got a sharp tooth. But what I'm also concerned about is that cough that you had. which it hasn't been investigated. So imagine if smoking can do so much harm in your mouth, where does it end up? In your lungs. So that's the one that I want to investigate with your GP. Organize a request a chest X-ray, make sure everything's okay, check your bloods as well. So with this version, we're more inclining towards trauma. Now, whether I should reinforce biopsy today or later, give an option, but I wouldn't force the patient. It might as well be traumatic ulcer. So we say now, in terms of investigation, so one option is we can smoothen the sharp tooth and then monitor you and then book you in and review in 2 weeks. If it goes away, great, we're on the right track. If not, then I'll refer you to a specialist and let's do a biopsy. Or option 2 is we can go for a biopsy today as well, given the site that this is. So patient says, so what do you suggest? We can wait for 2 weeks as well. So there's no harm. So this becomes also a very important assessment area. If you send a traumatic ulcer for biopsy, they will mark you down because we're just occupying the system, right? So there's a very long wait times. But if you get this in the exam, this is urgent biopsy. Look at the roll margins. Look at the appearance. You're telling the examiner, I am seeing the lesion. I'm looking at it. I know what looks like a cancer, not just the site only, not just the duration only. The appearance matter. It's in your teaching. So if you get this photo, I'll say now, well, in your case now, given where this ulcer is and also looking at the rolled margins, the size, the appearance, I would suggest we go for urgent biopsy. Do you see like the difference we go between these two? What investigations we're doing? Investigations we're doing here is, most importantly, I want to hear examination of the lung in the neck. Very important. So, because this is where these drain into the lymph nodes, mats can happen here. When you're doing inside the mouth, examine the red zone areas. You need to check not only that ulcer, you need to check the floor of the mouth, underneath the tongue, back of the mouth. And then check the tooth. Take an X-ray of the tooth. Remember, I have a sharp tooth. I've got a filling. Take an X-ray of that. The X-ray has got its own points in this case. You have to take an X-ray. And that's pretty much it. So we say right now, in terms of what we're going to be doing today is, I'll do a thorough examination. So would it be okay if I check for any swelling lumps on your face around your neck? Because sometimes, we start to see some lumps in these areas because of infections inside the mouth. Now, also, I'll be looking at this ulcer, take a couple of more photos. I'll be checking the size, shape, texture. I'll be examining the floor of the mouth, underneath the tongue, back of the mouth. And also the tooth that you mentioned is sharp. We'll take an X-ray of that tooth as well to see what's going on and the filling that you have and if that requires any redoing as well or not. And that's pretty much it. So we've already covered these part before. Now, preventive advice is around stress and just talk about how the patient can manage their stress. That's pretty much it. So very, very important. This chest X-ray is very important in this case. Any question?
So in the traumatic ulcer version, the patient is not smoking and not drinking alcohol.
Like I said, all 90 to 95% they're smoker. Right? The only there was just this one batch that I came across where the examiner said, no, I don't smoke and I quit. And they quit recently.
Mm-hmm. And so in that case, most of the time, our preferred is to refer to the GP for chest X-ray.
Your main aim is cuff, find this cuff. If you find a cuff, urgent chest X-ray blood test is mandatory.
Okay.
If there is no cuff,
Mm-hmm.
no problem. All right, I'll just do blood test. But now biopsy for the tongue, you have to look at the lesion. What does it look like? This is one of the photos they give in the exam. If it's like that, this is not cancer. Look at this.
Mm. Okay. Even if the patient, okay, got it. Thank you.
Right? So tongue cancer is different. Lung cancer is different. So you have to have separate set of questions for both. Okay.
Sorry,
Any other
doctor. With the X-ray that you are taking, is this actually related to the ulcer, or it's just a separate thing that we are doing just to check the tooth? Or because I don't see the relationship with the ulcer.
Okay, that's a very good question, Sid. So remember how I said I've got a sharp tooth, right? So if I have a sharp tooth, then some part of my tooth might have chipped off, or the filling might have chipped off, right? And that sharp tooth led to this. Now, would you fix the sharp tooth without taking an X-ray, or would you take an X-ray and then fix it?
I would say depending of like how it looks like, would just round the sharp area or
And the last checkup was 2 years ago, right? So what does your guideline say if a patient comes to your practice, they haven't had any X-ray, and they're
okay.
saying, I've got a sharp tooth.
Okay, now that now that makes sense. Thank you.
All right. Now that's important. So you have to look at how long ago. I didn't have any X-rays, so you're gonna take an X-ray of the tooth before you fix it, and then also that sharp tooth was connected.
Got it. Got it. Thank you.
Yes.
If we have got this picture of that is a white halo around and it's a traumatic ulcer, we have 1 month the duration and the site, that lateral border of the tongue. Still, we do not emphasize on the biopsy.
So that's where I'm talking about. ADC likes to play with your cognitive dissonance. They will give you some facts, shift your brain, right? So what happens is I'll say 1 month and tongue. Now your brain is stuck there. But what happens, you have to look. If I go back to TG, I think we have in TG. Remember those red flags that TG talks about?
Yeah.
So in those red flags, it is very important that if this part was given, so you can see that it was mentioned rolled margins. It was not there.
Yep.
And think about it, when we send this patient for a biopsy, number one, the hospitals are very busy. And when you send for a biopsy, this patient has to maybe wait for about a week. Now, the mental stress. I remember there was a girl, she's doing ADC exam. She called me up the other day, and the doctor said that she might have dysplasia and she's waiting for biopsy. Not inside her mouth, just in other parts of the body. And she was talking to me. She called me up because she was really distressed. She's like, I cannot focus. So even though the doctor said, I'm suspecting, she was like, I'm done, I'm doomed, I'm dying, I'm just writing my will. So that's where you have to be very careful with what you announce. So look at the appearance. And if it does not align, just tell them, well, the site and the duration, yes, it's a red flag, but the appearance is not. So it could be simply traumatic ulcer. Look at this one. This is traumatic ulcer. How big that is. So that white halo is a good sign for me. This is TG. All right. So this is what they were checking in the exam. So they will ask you, should I go for a biopsy now or later? So if I'm suspecting a traumatic ulcer, I'll say, look, given the site, yes, you can go if you want. I'm happy to organize a biopsy. The other option is, I'm more inclining towards traumatic ulcer. So we can just remove the cost. It's just 2 weeks. If it goes away, great. We're on the right track. If not, you're going. Okay. So that's where we come. So this is also a chronic traumatic ulcer. Sometimes these traumatic ulcer, when they are chronic, you see, they also develop these road margins. And they do look like cancer. This is from SORMS. It says a chronic traumatic ulcer present for several weeks may mimic malignancy. They sometimes develop crater-like with roll edges, but roll edges is a red flag for me. Roll edges, the appearance, I would go urgent biopsy, whether it's traumatic or not. Send this patient. Okay, and that's how you're differentiating in that aphthous ulcer red set. Because in that case as well, they're asking, how can you differentiate aphthous from ulcer, from traumatic? So in that case, we said aphthous has red margins and traumatic has white. In this case, cancer has rolled margins and this one has white. Done. Any other question?
Hello, Dr. Nazia. I have a question. It's Regarding asking the cough question, do you have any persistent cough or anything? It will help us to determine like whether the patient is having any disease in regards to the lung, especially if cancer or not, but how it is connected to the presence of ulcer on the tongue.
Very good question you've asked. Now, all of these cases that we're talking about. So, what the ADC is doing, you know that how smoking is harmful to our body. Smoking affects us in many different ways. Now, we've got so many cases where it's connected to oral cancer, we have periodontal disease, all of this. But you know that smoking just doesn't affect the mouth. Smoking damages the body. We have cases now in the exam where patient has hypertension, our patient has stroke, patient has heart condition, all because of smoking, right?
Yeah.
So what we're doing is that we're trying to find now these patients, you cannot make them quit smoking. So but when they come to you for a dental problem, you have a responsibility as a health practitioner to use that opportunity and get them to quit smoking. This is what the guideline says, right?
Mhm.
So
Mhm.
in this patient, whether the smoking, because of smoking, patient ended up as a squamous cell carcinoma or not, it doesn't matter. But you know that it's damaging the lungs if they have a and smoker's cough. And what if this patient quit smoking and they started vaping? Do you know what vaping does? Vaping also damages the lung. Do you see there's something we call it as e-cigarette and vaping associated lung injury?
Yeah.
Vaping, smoking, and mouth is just a passage. It passes through the mouth. Where does it end? In the lung. And this is what we're worried about. Now they use the word very specifically in the exam. They said, I have smoker's cough. They use this. So when they said smoker's cough, and that's where I went on a search, and this is from Towson, page 449. It says, clinically, those that have bronchogenic carcinoma, this is our book, pathology. They say recurrent cough is the most common feature and often ignored as a smoker's cough. You see? I've seen ADC, they use those specific words, and those specific words are keywords. They're trying to tell you something. They're using this word. Now, this is early feature. If you ignore this, later manifestation is now they will have chest pain, now they will have weight loss, anorexia. So the most important thing, we catch them here because early diagnosis means they have a greater chance of survival. Right? Now, if you look at from a stats perspective, lung cancer is more common than oral cancer. Right?
Yeah.
So that's where we're using the mouth as a tool to saying quit smoking. So cough is very, very important in this case. Please do ask about cough. So I'll go through it. And I know many people have failed because of cough. They knew cough was there, but they were like, oh, I just don't feel comfortable bringing that up.
Yeah, yeah, because the patient is here mainly because of the ulcer on the tongue, right? So we have to ask question why the ulcer is been happening. So that we don't really feel the importance of addressing cough because as it is related to the lung cancer thing.
Yes. So like I always give the example of this one. Again, I'm going to bring this case again from the silver set. Right. This is the very classic ADC language. This is a cluster 3 patient taking Aliquis came for a post-op instruction, right? Now, if you technically think about it, it's just your job is just to give an instruction and just forget about it, right? But now they are now giving you a hint. They're trying to check. Can you read between the lines? This is where they're testing your intelligence. They say mobile 2-3, previous extraction, right?
Mm-hmm.
They are telling you there's a very severe perio going on, right?
Mm,
And then
yeah.
they're saying patient smokes. Now you think, oh, smoking, dry socket infection. Yeah, I get it.
Yeah. Mm-hmm.
But it's much deeper. Patient is worried about, you see, patient does not have stroke. Patient is trying to prevent stroke,
Yeah.
right? So what led to that stroke? Increase the risk of smoking, right? So this is how they talk to you in this case as well. And the whole idea was in that silver set, get this patient to quit smoking. Now, in this case as well, the idea is get this patient to quit smoking, cut down on alcohol. It's not good. It's costing government a big amount of money. So these health promotions are extremely important for us to do.
Yeah.
Okay.
Okay.
So so do you see like most death from smoking are due to lung cancer, not oral cancer? So sharp tooth was there. Now these I'll just go through the exam questions that came in the exam. And in these cancer patients, if you did not prioritize preventive advice, like I said, spoke about this girl, she failed. She said, I did not have time for preventive advice. I went on, spoke about traumatic ulcer. So the only two differentials you're going to give is traumatic ulcer and cancer. You will only talk about AFPIS if they give you a previous history of ulcer positive. Otherwise, don't even waste your time. Don't bring that in. All right. That's the whole idea of taking the data. In the T, I'm asking, did you had any previous episode? If the answer is no, that means no AFPIS. Don't bring it. So blood test was done 12 months ago. Patient said it was fine. This patient was a smoker and drinking alcohol. In this case, patient does say that I heard red wine is fairly healthy, isn't it? So look again, when they say wine, a glass of wine holds much more than any other. So remember, when they say wine, think about the glass of wine. A glass of wine will hold about 1.8 amount of standard drink. And if they're going to have it every night, so think about it, about 14 standard drink. So we're already crossing the limit. Patient said, I do have smoker's cough sometimes. This girl, she asked, she's like, I just asked the patient, do you so the other girl, she got this case, and the examiner was saying that there was a filling that chipped, and there's a sharp tooth that irritates my tongue. Spicy food and crackers irritated. Patient kept saying, well, I don't know. I've only noticed it about a month ago. But I haven't. Now, if you look at the tooth as well, do you see there's a bit of attrition on these teeth? Look at these ones. Right? So that's why I asked them, do you recall biting onto your tongue? Because sometimes when they're stressed, they're grinding. Now, anyway, this guy did ask the examiner, do you grind your teeth? Patient said, oh, wouldn't I know if I'm grinding my teeth? He was like, no, I just looked at your teeth. But that's a coincidental finding. Now, but regardless, this was a teacher, a very stressful job. Now, how did the patient talk about it? Patient said, I smoke heavily. I am trying to quit, but I find it difficult. I smoke 1 pack a day. And patient said, is it really important to quit smoking? How does smoking affect our oral health? Do you see the questions that are coming? It's all about that. So just tell them smoking doesn't just causes damages your mouth, it damages your body as well, which is what I'm worried as well. Now, patient said, I don't know what's causing. Can this be serious? Is this cancer? Yes or not? For this, they need a clear-cut answer. Now, the other girl, she got this case. Now, the examiner was very good. Even though she failed, the examiner was actually cuffing. This examiner cuffed in the first 3 minutes. And he said, oh, it's just, I had it for a while. It's not a big deal. Patient was not willing to quit smoking. Patient said, I can consider in the future, but I'm not considering it just yet. Again, a school teacher stressed. This is always a school teacher stressed. Fix that stress. And how would you talk about stress in this case, stress management? What do you think?
What do you do for stress management?
So when somebody's stressed, stress normally happens when you don't have free time. It always starts from the burnout, as we say in professional language, right? So what do you do when you're giving them advices? Don't send them for long walks. First, give them an idea, free up your calendar a bit. Okay, my life. So we say, all right, well, look, I know, you love your work and I know you're working long hours, but do you actually get time for yourself? Not. Okay, well, can we start from there? Maybe, just find some pockets of gaps in your calendar, do something that you enjoy, and maybe over a period of time, you will find a big change in the way you feel. Do you see, like, start with calendar because this was a patient that was overly working. Now, this girl, she got this case and she got this version, roll margin. So patient was coughing, patient was not willing to quit smoking, teacher and stress, and she got the version where there was roll margins as well. In this case, yes, I will send for biopsy urgently, and I will send for a chest x-ray as well urgently. Two things. Could be a squamous cell carcinoma and a lung cancer. Can be both or either, but do both. So she forgot to send this patient to a GP, even though she did a biopsy. She forgot preventive advice, she forgot chest x-ray and blood test, and she failed. So that was this case. Then this was another one. Patient said, sometimes they say in the roll margin in this version, patient says, got few things lined up at school. Can I delay it for a month? No. In this version, I say, well, look, Mrs. Cooper, look, if I were you, I would prioritize for once, your health, because where this ulcer sits and it's been for a month and the way it appears, I don't think it's a good idea to delay it any further. Let's just get that done, right? In this case, that's how you create the urgency. Is this cancer, doctor? Just say, well, look, Mrs. Cooper, I wish I could answer that question. Look, I cannot say that with surety by just looking at it, but yes, that's another thing that I'm considering on top of could be traumatic ulcer. You see, you are not denying it, but at the same time, you're explaining to them the urgency of it. Then patient was, again, another version. Yes, the same. Any other question for me?
Doctor, if the ulcer with roll margin like this picture, what blood test the patient should do?
So normally when we send them for a blood test, now remember any cancer patient, when you send them, we request their GP for a full blood count. Now the full blood count would include white blood cells as well. And it will tell a lot about their immune cells. Of course, we also check their vitamin D and all those. So we say full blood count.
Thank you, doctor.
Okay, the other patient said, I am fond of, I love French fries, and maybe it got injured because of that. So that was another version where sharp French fries injured, or sometimes they bit, but different reasons they give you, or broken filling, or a sharp tooth. All right, done.
Doctor, what preventive advice we should to give to the patient?
So preventive advice, remember all versions. Stress is the fundamental part of it. Stress is the essence of it. So stress led to smoking alcohol, and stress led to poor diet, and that's what led to cancer. So preventive advice will go back to managing stress in a healthy way. Because if they manage their stress, then they will not get into those skip their meals, and they will not reduce alcohol and smoking, right? And how I spoke about freeing their calendar, getting some time for themselves. That's it. Don't go with big long exercise. Some people say go for yoga. Patient was like, I don't even like yoga. All right, so don't suggest them anything. Patient knows what they like best. One of the examiners really took a viva. They said, oh, how many times for biopsy? So she got this version of traumatic, and she said, we need to do a biopsy. Then the examiner's like, oh, okay, now tell me how many types of biopsies are there? And then she got stuck. See, again, normally for small lesions, we do excisional biopsies. Or sometimes punch biopsy can also be done, but again, I wouldn't do it. I know we had a session with Dr. Peter. He was saying that, oh, you dentists can do it. I mean, dentists can do it, but in exam, don't do it. So he was saying that, you guys should be doing punch biopsy. So easy. We're like, Dr. Peter, they can't do it in the exam. Sorry, they're going to fail. Yeah, but that's what they do in the hospital as well. All right, done. So moving on. Remember this case, whenever I say ulcer
Sorry.
on the tongue, think about lung cancer and squamous cell carcinoma, two things, and then rule out what you're getting in this case.
Sorry, Dr. Nazia, I
Yes.
have a question. To wrap up the notes that you mentioned regarding referral to a specialist, I found that if we can identify an obvious source of trauma, we would remove it and review the patient within 2 weeks. However, if there is no identifiable traumatic
cause, or if the lesion has suspicious features such as roll margin, induration, fixation, and or if would be unexplained ulceration or persistent ulceration, we would refer it promptly for a specialist assessment. Am I right?
Yes, but there's something else that we're talking about. Yes, so if it's traumatic ulcer, given the appearance, yes, but remember there are some red flags as well, okay?
Yeah. Okay. Thank you.
Yeah. So just remember, white biopsy is an option. Right now, today's my recommendation is fix this, review in 2 weeks, then biopsy, but biopsy today can be done since red flag is there. But my recommendation is remove the cause and monitor. If I get this version, urgent biopsy, remove the cause, urgent biopsy. That's it. Okay? These are the two versions you get in the exam.
Thank you.
All right, so let's move on to the next one.
Hi, Dr. Nazia. Can I please do the cluster 3 consent for extraction?
All right. All right. Yes, let's do that one. And you thought this one is easy. Okay.
Yeah.
All right. Now,
Thank you.
consent cases are a bit more tricky, but okay.
Yeah.
Cluster 3. So now when we talk about cluster 3, we're talking about, as the name says, treatment planning. You haven't removed the tooth, and there is
Yeah.
a difference between this case and those cases that where we've broken the tooth, right? In this case, you haven't initiated yet, so you have a choice whether you want to do it now. Explain to me. So again, supported decision making we
Yeah.
need, and more importantly, how are we going to manage? What is the main health promotion in this case? So it revolves around that. So here we go. 3.
Yeah.
All right. So
Yeah.
if you're ready, here we go. 10 minutes.
Yeah. Thank you, Mrs. McKenzie, for being so patient and let me examine you. So before we proceed any further, I just want to explain you a bit about the findings that we see today. If you look with me in the X-ray, so there is like this radiolucency, like a shadow, if you can see in the crown part, the top part of the tooth. So
Yep.
you can see some of the margins are broken down already. So the tooth has been decayed, like it had some bacteria over there that have re- eaten the tooth structure a lot. So this tooth is badly infected in there. So
Oh, is there?
with this kind of tooth, there are some troubles in restoring that. Like it will be hard to isolate the tooth from the surrounding environment while we are doing the procedure, which puts it at a risk of having the infection again. And it would like eventually fail the treatment that we do on it. And if you see it a bit more closer, you see this root over there. That's the longest root of the tooth. We call it the palatal root. Can you see it with me?
Yeah, I can see that, doctor.
Okay. So do you see this white line that I am showing over here?
Yep.
So this white line demarcates the hollow spaces that we have in our face. We call it sinus. Have you heard the name before?
Yeah, I think I do. Yeah, but I would like to know more about why you're bringing that up.
Okay. So the thing is, usually there is a bony gap, a space between the roots and this air space. But in your X-ray, what I can see is your roots are in very close proximity to this one, which puts the process of extraction a bit complicated, you know. So it will put a bit of risk of slipping the roots into the sinus or creating a gap over there. We call it a communication, oroentral communication. So if those are the cases, then we have to do our management a bit differently. We have to go towards some specialist treatments. Sometimes, if it's the major complication, if it's a small one and manageable, we can do it on the chair side. Okay.
So you mentioned about this complication. Like, is that something that happens quite often? Is it a common complication?
So it's not that common complication. The common, I would say, are related to the procedure itself, like maybe minor bleeding or something. This is due to the anatomical variation that we have. So we
So
have a
then,
risk.
so then, is there a high chance in my case?
There are chances. Yes, I would say that.
So then,
So,
doctor, do we really have to then remove this?
well, the infection has gone a lot higher in the roots, and what I can see through the x ray, if we try to prevent the extraction, the root canal is not going to be easy because your canals, if you see in these roots over here where I'm pointing, so
Yeah.
I can't even like demarcate the canal in there in your roots. It all seems to be white in color, all seems to be calcified. So, which makes it a bit more harder to restore. And if we want to restore, then we want to make sure the prognosis is good. The amount
So,
of money
why
that,
are you remove? So why can't we save it? Is it just because it's badly broken? Is that the reason why?
no, usually it's more towards the longevity of the treatment as well. Like
Okay, all right.
if we
So,
try to,
so would you be then removing my tooth today, doctor?
with removing, we have two options. Either I can try it, okay, or we can send you to the specialist. So the specialists are a bit more trained. They do deal with these cases on more frequent basis, maybe like more often than me, of course. And whichever you prefer, we are happy to go
Look,
with
doctor,
that.
I don't have money for the specialist. I was thinking you would be able to treat my tooth. So,
But I can give it a go. Don't worry about that. If you're happy for me to give it a go, then I would like to explain you how we will try to do it.
okay. So, how would you go about removing my tooth?
Okay, so usually we numb the tooth first. for numbing, we put a gel first on the top so that when we inject the solution inside the tooth, it does not give you that intense pain. It will feel like a pinch probably. And I will try to be as gentle as possible, I promise with that. And then when the tooth is completely numb, I will use some instruments to take it out. You will feel pressure and some bleeding in your mouth, which is normal. And after that, we can
But
stitch
then,
it. Depend.
doctor, so I won't be experiencing any pain as you remove my tooth?
Hopefully, you won't be feeling any pain. But if at any point you feel pain, you can raise your left hand, and I will address that.
Okay, all right.
Okay.
Okay,
And
all right.
after the procedure, I will put a gauze in your mouth, a gauze swab, just for 15 minutes. You have to bite on it so that we ensure that the bleeding has stopped and a nice clot has formed initially over there to cover up the wound.
What's a clot?
So, clot is a blood, when we plug the sink, sometimes we put a plastic thing in it. So, clot is the same thing that works in here. On this wound, our blood will accumulate and blood will get harder and it will
Okay.
plug that area. It will secure it for further healing.
Okay, all right.
Okay. So, if you understand it well, do you have any questions with it
Well,
so
I
far?
just want to know, so for how many days would I be experiencing pain?
Okay, usually in the initial 48 hours, pain and a little bit swelling is normal, and we can give you some painkillers to support you with that. After that, it usually reduces and goes away. But if in worst case scenario, if it becomes like hard for you to open mouth, if you are experiencing intense pain or some extra bleeding even after 2 hours, if you have more bleeding, then just let us know and we will help you further. With the bleeding, we suggest, we will give you some spare gauze packs to take home with you. You can put another gauze and see it for another maybe 15 to 20 minutes. If it stops, well and good. If not, and our clinic is open, just contact us and we will guide
Oh,
you
you're open
further.
24 hours? Can I contact you at
No,
like 11
no,
o'clock?
no. No, I'm sorry about that. So we are open until 5. So if it happens, like I will assume this is the afternoon right now, okay? So if it happens before 5 and we are here and you're available, we are happy to help you. Otherwise, I will suggest to go to your nearby hospital as soon as possible. They will be able to guide you further.
Okay, all right.
And the
But what if
area
the
would.
pain does not settle? What if, you're closed? What am I going to do? Like, what could be the reason for that?
Okay, so if the pain does not settle, usually it depends if it's more on opening the mouth or closing the mouth, or if there is some infection developing, and after how many days the pain is still lingering on. We usually review the patient in 24 hours. Like my reception can call you and check if everything is going on fine. If you have any trouble, you are welcome to visit us again. If it's again after hours, I would highly suggest to visit the nearby hospital and we can increase the pain management. Like usually I suggest my patients to take ibuprofen, but if it's a bit more pain, you can add paracetamol with it. You can use it alternatively. Is it okay generally for
Uh,
your health? You can
yeah,
use
yeah, yeah. I
ibuprofen
can,
and
I can use
paracetamol?
that. I can.
Okay. So initially, that's how we go. But if it's the worst case scenario, you can visit me in my working hours or you can go straight to the hospital.
Okay, all right. So what am I supposed to be doing today?
Okay, so today, after this, you just have to avoid eating hard foods. You have to avoid the hot temperature foods. You have to avoid biting your lips, your tongue, so that nothing, because you will be numb, you won't be able to feel it. So I
Oh,
would
I won't
suggest
feel
not.
anything at all?
No, no, you will feel the pressure sensations, but you won't be able to feel the temperatures.
Oh, okay.
Okay? So I would suggest not to eat anything for next 2 hours, and then just for 24 hours, please avoid brushing on this side. After that, you can continue the daily oral hygiene. And you can use the salty water rinses. for up to 1 week, starting from 24 hours after the treatment. Okay,
Okay.
and
All
we can
right.
continue that for 1 week.
Great. Thank you so much. All right, Anila. So first role play. Great. How did we go?
I think I was a bit here and there, not 100% on the track.
No, tell me about it. I'm always here and there. But generally, what's the focus point in this case?
Okay, so the focus points were to explain about the palatal root, which was the major complication, and the patient.
Was that the only one?
No, we have more. We have the oroenteral communication. We have to explain about the trismus, and I had to explain the long-term treatment, which I didn't do in there. Just to
All
touch
right.
base on that, as you said.
And what's the main
Oh, smoking! Oh my God.
smoking? Yes. You
Yeah.
see, all the cases are built on health promotion, right? So we're talking about all the different aspects of smoking. So let me just, oh, I can't share it. So when we talk about smoking in this case, this was the main message,
Yeah.
right? Now, how can I connect smoking with this? How can I get this patient to quit smoking?
So we can ask the patient if he is happy for us to discuss it, and then we can refer him some quit line to GP, and we can provide him some brochures for information, and we can explain him how it does the vasoconstriction, how it narrows down the blood supply to the area, how the direct effect would be the heat trauma by the smoking,
Mm-hmm.
and how it
Yeah.
affects the health overall very badly.
Yes. So that's one aspect. Very nice, Neil. That's really good. Now let's look at from a different. So remember we said that these patients are very stubborn. I mean, these are the patients that are killing themselves with smoking for years and years, and I'm sure their doctor would have been telling them, don't smoke, don't do this. This patient is not learning any lessons. So what did we do in the previous case? In the previous case, we scared this patient. We said where there's a potential of cancer. Now, whether it's inside your mouth or whether it's happening in your lung, I'm worried. And we had to investigate both organs for this patient. So we were using that ulcer as a tool to get him to quit smoking. Now, in this case, this patient has been smoking, and you know that when people smoke, they have more cavities. The
Yep.
caries rate is very high. Also, now I came with a painful truth, right? Now we
Yeah.
say pain is a very good teacher. So this patient wanted to get rid of pain. My son was talking to me today about an experiment that he saw. There was a white room. There were people were sent into this room. They were asked to completely white with one buzzer, 20 minutes. They said, you just have to sit for 20 minutes and that's it. But if you get bored, press the buzzer, and that buzzer would cause pain. But people couldn't sit. They were pressing the buzzer. The pain was something they tolerated, but they couldn't sit with themselves. So the main idea was that like pain. They were using pain as a teacher, like, just to avoid pain, just sit down, calm down. So here, I was worried about the pain. This tooth was very painful. Now, what was the diagnosis here? It would be given on the screen. Sometimes it's given as irreversible pulpitis. And sometimes it comes as a spreading odontogenic infection. Okay, so two diagnoses we get in the exam in this case. So double check always. So what is the workflow? How should we go in cluster 3? In cluster 3, you only take a bit of data. So first minute is for you to 20-second ask the patient. I'll say, all right, well, look, Mr. McKenzie, so I was looking at your tooth and I quickly took this X-ray as well, so I can show you. You were mentioning earlier about your tooth on the top right side causing pain. Patient said yes. Okay. Now, I will be confirming a few details and then we can also discuss about what we can do best. No, tell the patient. All right. So, could you just confirming a couple of details? Could you tell me more about the pain? I just want to confirm the pain. I wanted to see which version am I getting. If it's not given, I'll double check. All right. If it's given, great. just say that. So you mentioned with this tooth, so has it been mainly sensitive? Have you noticed any pain on biting as well? All right. If there's pain on biting, then if you're not removing the tooth, you have to give me antibiotic. Spreading infection, whether you remove or you don't remove, you have to give me antibiotic. Do you see? So that's what we ask. So patient said, so let's say I was doing this version. I say, well, look, doctor, this tooth was very painful. I couldn't sleep for many nights and to a point that has become unbearable. Oh, hi. Well, that doesn't seem to be good. Okay. And with this pain that you've been experiencing, so did you try taking anything to relieve it? And patient says, yes, I took painkillers, Panadol, and it didn't work. Okay. And have you also noticed any swelling around your gums on your face? Just confirming. And the patient says, the version that I did, yes, I have swelling on my face. So there are many OSCEs that have spreading infection, including this one. All right. So double check swelling on the gums, swelling on the face. Ask them. These are two separate questions. Then I would have said, yes, I've got swelling on the face. I'd say, okay, well, thanks for sharing that with me. So let me just walk you through what we can see. Now, do you see this tooth? There was a hole inside it. Now, because it was not treated, bacteria have gone inside the tooth, irritated your tooth. Now, what it seems like your tooth probably might have died, the nerves are dead and infected, and that infection has gone onto your face. So we call it spreading odontogenic infection. And we need to treat this condition because it can become life-threatening. Now then pause. Any question? Now, do you see, I said we need to treat this condition. I did not announce that we have to remove this tooth or save the tooth because I want to ask the patient this question. So I'll say, all right. Now, Mr. McKenzie, sir, so what were you hoping that we might do for you today? What were you thinking, we could do for your pain? This is number one, very important area. Now, the first argument that comes is patient one was thinking you would save the tooth. And now, if you start talking about extraction, you're going to get it. So Anil did really good. She started with saving the tooth. But how about we ask the patient? So, right. So so what were you thinking we might do for this pain that you're experiencing? What sort of treatment did you have in mind? I'll tell you. I'll say, well, I was looking if you could save my tooth. Okay. Oh, well, we could certainly look into saving this tooth, but there's a couple of issues that I see with your tooth. Now, this is very important. So you get two versions in the exam. One version, you get a badly broken tooth. Second version, you get blocked canals. So you have to see which version you get. And both versions, even if you can't, specialists can do it. Just give them the reason. So I was doing this version. So we say, all right, well, Mr. McKenzie, look, I would be more than happy to save this tooth. But the problem with the treatment that we normally do is what we call root canal treatment. We use those very delicate files. We go into these channels, we call it canals, where these nerves live, and we remove them. Now, in your case, can't see it properly. So what it seems to me, possibly it might be blocked. And if I try to negotiate, I can break my file, it will cause complications. So if you really want to save this tooth, I'm happy to refer you to an endodontist. But if you want me to do it, unfortunately, I can't. The only thing I can do for you today to get you out of pain is to remove this tooth. Do you see? Gave the reason, came back. I did not talk about rubber dam. I did not talk about because it was a block canal version. If you get the version where it's badly broken, like sometimes they give you this entire thing is gone and the patient wants us to save it. So we say now, Mr. McKenzie, now look, I would love to save your tooth because there's nothing better than having your own teeth. But there's a couple of issues that we can see. Now, the first thing that we need to consider is restorability of the tooth. If you can see there's barely anything on top. And, even if we try to remove the nerves, we try to do something we call root canal treatment, long term, placing a cap on this tooth is important. And in your case, it's not possible. Also, it's difficult for us to place a rubber sheet. We call it a rubber dam. Again, there are ways we can get around it. We can put it on neighboring teeth. And third thing also, it's difficult to negotiate these canals. So for these reasons, if you are looking into saving this tooth, I'm happy to give you a referral to an endodontist, but unfortunately, I can't. You see, I'm showing, this is my cluster 1 professionalism, showing my limitation, explain the reason, and then now. So I go back to the pain. The only way that I can get you out of pain is removing this tooth. Now, when you talk about extraction, go back to their history, because think about it. Have they removed a tooth before? A lot of people get anxious and there is anxiety. That's problem number 2. So in this case, 1, they want to know what is the reason why you can't save it. 2, anxiety. So we say, all right. Patient says, okay, well, doctor, okay, that's fine. You can remove it. Okay. Now, say, now, Mr. McKenzie, just confirming, have you had any tooth removal before? Have you had any experience? No, I'm checking with this patient. Now, what do they say in the exam? One version. They say, yes, I've removed all of my wisdom teeth under GA a few years ago. All right, all 4. Again, if they removed under GA, doesn't mean they're anxious. Okay, so GA is, normally wisdoms are removed under GA, especially all 4. Then I'll say, okay, and how do you feel about, getting this tooth removed? Do you have any sort of anxiety? If you will, just ask directly. Patient says, I think, yeah, a bit. Yeah, I think so, a bit. Okay. Well, look, we have options. If you do feel anxious, I know, it's something that you came unexpected. I can walk you through the procedure. We have options about giving you tablets or giving you a mask to breathe. You let me know whichever option works for you. You see, I said, okay, tell me which one. Sometimes then they want to know about oral sedation. Sometimes they want to know about nitrous oxide. And sometimes they just say, no, it's fine. I'll just tell me about the procedure. Now, the other version, we ask the patient, so have you had any experience of tooth removal before? Patient says, no, this is my first experience. Oh, even worse. Okay, so anxiety. Now, this is assessment number 2, get to the anxiety. How do we get to the anxiety? Is through this. Now, the third area is that they want to know, how will you remove this tooth? Now, we need a consent. You have to explain them there's 2 ways to remove this tooth. Forceps, simple tooth removal with using forceps, or sectional, badly broken. So they want to know each one. So patient says, all right, now, would you like me, Mr. McKenzie, to explain you how we're going to remove this tooth? Yes. So we say now the first step is, of course, to numb this tooth. So we'll place a gel, let it work for a couple of minutes, then give you an injection. Once your tooth is numb, then there's 2 ways we can remove the tooth. One, where we can use our instrument, we'll hold the tooth firmly and then wobble the tooth out. Or 2, which most likely in your case we would need to do because it's a badly broken tooth or there's barely any structure on top. We section the tooth, we divide it, and we remove each root one by one. Now, with these options, again, at any point, if you experience pain, let me know. Raise your hands and I'll stop. And then pause. Any question? No? You see, I still haven't spoken about OSCE because it's something we'll talk about later. I'm revolving around pain. Everything is about pain. Then we say, all right, any question now? Quickly, what are the important surgical sequelae? So the first thing is we talk about bleeding, then pain. Very interested in painkillers. And when you give painkiller, check their history. This patient had hypertension. So we say, all right, now, Mr. McKenzie, so now, once we remove this tooth, you might expect some bleeding. Now, again, I'll give you gauze piece to bite on and some extra to take home. Just make sure that if the bleeding continues for beyond 10 to 12 hours, contact us, or if it's a considerable large amount. Now, pain is something that you will start experiencing maybe in the next hour or so. Just confirming. Has anything changed in your medical history? Now, this patient, the version that I was doing, I was taking blood pressure medication. Now, I had a detailed discussion the other day. I think this new teaching is so complex. There's this part that I missed, and one of the guys, he brought it up for me. And the section here. It was about myocarditis, when not to give to this patient. And said, let me see. They said, don't give to these patients that are taking angiotensin. It causes toxicity. Let me show you in TG. There was a section here. So yeah, in that case, you got to be very careful. Yep, here. So if you look at TG, severe kidney impairment. Now, previously we were talking about 3 drugs: ACE inhibitors, diuretics, and if you give NSAIDs, it causes kidney failure. Now, TG says NSAIDs should not be prescribed by a dentist for patients with severe kidney impairment. Now, acute kidney injury is a serious adverse effect associated with all NSAIDs. Risk factors, what leads to acute? They might not have a previous older age, 50 plus. Pre-existing kidney, this patient never had it. Conditions that reduce blood flow, dehydration, sepsis, this patient did not have it. Some classes of drug used to treat hypertension or heart failure. Do you see? Angiotensin converting enzyme inhibitors. So this patient was using Mycotis. Angiotensin 2 receptor alone or diuretics. You see? And in these patients, they say the risk of acute kidney injury is cumulative. So if there is increased risk if NSAID is co-administered with ACE plus a diuretic, or if it's old and then they're taking this. You see, so that's what, and in the all new versions that come in the exam, they're changing medical conditions, all cases. They're adding different medical conditions, especially in cluster 3. They're checking your painkillers. Painkillers are killing patients. So in this case, be careful. If there is no blood pressure, there's no blood pressure medications, I would give paracetamol and ibuprofen. But if blood pressure medication is there, paracetamol. It's enough. Now that's where the question comes. What if then the pain cannot be managed with paracetamol alone? It is possible because this patient was smoking. Now, the third thing you're going to talk about is smoking. We say now, so patient says, so, okay, well, thanks for sharing that. So now that you're taking blood pressure medication, then I might just prescribe you paracetamol. So you can just take it 4 to 6 hourly. And usually the pain will start to get better after 48 hours. Patient says, what if it doesn't? What if it gets worse? I'll say, well, yes, it is possibility that the pain will get worse. Now, if that does happen, what I would be more worried about is the wound that did not heal. Now, you mentioned about you smoking. Now, go back to the smoking history. Now, would it be okay if I ask you a couple of questions? So, how long have you been smoking? How many cigarettes? And then, do you know how smoking affects your health? Or health patient says no. Okay. Now, when you smoke, it makes your blood sticky. And I don't know if your GP might have mentioned that could be the reason why you ended up with hypertension, because it narrows your blood supply in all of your body. That leads to blood pressure and inside your mouth as well. When we don't have enough blood coming in, the wound will not heal. So when the wound wouldn't heal, then we might have an exposed area of burn, which we call as a dry socket, which is a very painful condition, or sometimes the area might get infected as well. So if you really are looking into avoiding these conditions, we have to consider quitting smoking either for good or either temporarily. Is that something you can consider? You see? So this patient did not learn a lesson with hypertension, but now I'm using this pain to get him to quit smoking. So this is where the negotiation comes. So patient says, oh, I can't, doctor, can I take shallow puff? Can I do it from the other side? So we'd say, well, so what do you find it difficult? Like, when it comes to quitting smoking, I want to know, is it the addiction? What is it? Is it the behavior? So patient says, well, it's just basically, doctor, my colleague smokes. So it's very hard to give up the temptation. It calms me down as well. I say, okay, well, look, I get it. That it calms you down and probably it's because of the nicotine. So have you looked into nicotine replacement options? I can refer you to Quitline. They might give you some options. Refer. Okay, so very, very important. If they're not willing, then I'll start with Quitline, then GP. So 3 things are very important in this case. Number 1, why are you removing the tooth? All right, so why this tooth cannot be saved? 2, is anxiety. 3, how are you going to remove the tooth, right? Which is a forceps and sectional. And the last thing is smoking. And all of them comes under the umbrella of pain. So that's pretty much I would go. Replacement option, if you have time, please talk about it. Otherwise, if you covered this, health promotion, you've done a good job. Now, OSCE, yes, talk about it if you have time. Very briefly, I wouldn't go into much detail.
Dr. Nazia, could you repeat those points?
So they want to know in the beginning why this tooth cannot be saved. This is right in the beginning. Okay, so you have to give them the justification. So either you get blocked canals or you get a badly broken tooth. Okay, but again, remember, give them second opinion with the specialist. Two, who's going to be removing this tooth and how? So how it's forceps, or most likely this is a sectional tooth removal. You can't go with forceps with this one. Three, anxiety. And fourth is smoking. Smoking leads to dry socket, infection, delayed healing, pain. All right, that's it. This case has got a very high fail rate.
you.
So I'll go through the questions. So smoking is positive. So this patient was smoking more than 25 cigarettes per day or 20. If it's above 20, highly addictive. These patients will not give up smoking very quickly. So ask them, how does it fit in a patient's life? And let's start with nicotine replacement, at least for 48 hours. And this could be the beginning of maybe considering quitting. Now, patient was asking too many questions. Now, will they tell you, oh, doctor, I'm anxious? No, they will not tell you. They are waiting for emotional intelligence. So how will you know if this patient is anxious? One, when you have explained the patient everything, why this tooth cannot be saved. For example, I get this badly broken. I say, I have already explained to the patient this tooth cannot be saved because it's hard to place a rubber dam. It's difficult, restorability is questionable. Getting into these canals, negotiating is difficult. So I'm happy to give you a referral, but I can't do it. And then I move on and patient says, but doctor, why are we removing it? And then you repeat again. Don't repeat it again. That's one way that they're telling you I'm anxious. Just pause and I say, well, look, I already, we already discussed why we decided to remove it, but are you okay? Are you feeling anxious? Talk about it. Two, go back into their past history. Have they had a tooth removed? If not, how do they feel about it? Anxiety. Three, ask them directly. Well, look, we're going to remove this tooth. If you do find yourself anxious, let me know. We have options of managing it. So with this girl, the examiner was asking too many questions, talking fast, and that was the sign. Patient was anxious. Patient removed all wisdom under GA. With her, the examiner asked, what replacement options can you provide? A smoker implant, I wouldn't give. So you have to look at the neighboring teeth, either a bridge or a denture. For sinus complications, again, very briefly, we already have many cases of sinus. I'll just, when you talk about complications, there's a few complications we talk about. One, which is the most common one. So we say, as we remove this tooth, there is some complications can happen where we can break the top part of the tooth or the roots, or we damage the neighboring teeth, right? So these are the common ones that we see, or where the bleeding can become unmanageable, or the pain become excruciating because the wound did not heal, or also sometimes because of the proximity to the sinus, either I can push it in or I can create a hole called oral communication. Would you like me to explain any of that to you and see which one they choose? So roots are always inside the sinus. Remember, it's a 2D image of a 3D object. So double check, take another X-ray. Examiner said, explain everything. Tell me how you're going to remove this tooth. I am in pain. How will you send me to a specialist? No, yeah, I'll remove this tooth. Patient, when asked about smoking and alcohol, patient said, I don't want to talk about it. So examiner was really not keen on quitting smoking or having discussion about smoking. Was very adamant. And patient had irreversible blepharitis. So in that case, I guess the way that this girl asked question was again is not what the examiner liked. Then the other girl, she got this case. The examiner said I had extraction before, and one of my friend told me that she also removed her tooth and she had a very painful experience. Why did she experience pain? So her friend had some dry socket. Okay, so quitting smoking is important. What else was here? If they want to know complications about sinus, they're mainly interested in OSCE. Otherwise, they're not. Smoking, they said, I tried quitting smoking, it didn't work. Please, smoking, very important again, another case. So the problem with pink set is, if you look at pink set, technically, there's quite a few cases that we have smoking, isn't it? In this case. So I'll just open it up for you. And all of these cases are important. Let me open up the clusters. Okay, here. I want you to highlight these ones for you. Which one has smoking, which one doesn't? So, ulcer on the tongue? Yes. Smoking, we're talking about from a cancer perspective. We did periapsis yesterday. Again, smoking was very important. We spoke from a gum disease perspective. Then we had another case, consent for extraction that we're doing now. Again, smoking was very important from a wound healing perspective. And next week, when we talk about non-healing socket again, smoking, another cancer patient. Do you see? Perimplantitis from a gum disease, variations of these ones, but all focused on smoking. So that's where the OSCEs, this is how OSCEs are designed. Then the examiner said, now replacement options, they're not interested, but what they're interested is, why should I replace? Why? So when you say, well, look, also, once we remove this tooth, we also have to consider giving you replacement options in order to replace the tooth. Patient says, but why do I need it? So, well, look, if you don't replace this tooth, your neighboring teeth will start drifting into that space. Patient said, the other girl, she got this case, the patient said, well, I do get very anxious, so I want nitrous oxide. Can you do it? Oh, yeah, you can do it. They're not going to check your license as long as you know. Nitrous oxide, all you need is certification. You can do it. It's not a big deal. What else was here? How long should I quit smoking? I say, well, if you can do it forever, it's great. But if not, at least 48 hours. This guy got this case and this patient had facial swelling. All right, any other question for me? So just focus on the critical assessment areas that I said, okay? Anxiety, why we're removing this tooth, right? Why it cannot be safe? And how smoking can be linked to this entire tooth extraction procedure. That's it. These are the major assessment and why the tooth should be replaced. Nothing more.
So we give both the options of nitrous oxide and sedation.
Yes, always say that if you get anxious, we have options by giving you a tablet or giving you gas to breathe through. Would you like me to explain? Then patients say, oh, tell me about nitrous oxide. Okay. So give them always options and see which one they pick. But if you start picking it, what if they don't want to hear that option? So I wouldn't do that. All right. So in this case, we're using pain as a teacher to get this patient to quit smoking. Pretty much that's it. All right. Great. So if no questions, we move on to the next one. The next one is interstate. Oh, another pain case. So in Pink said, we're dealing with two endodontic emergencies as well. So this is how you need to look at these cases from a bigger perspective. So one is this patient going into say this is about a patient with a hot pulp. And yesterday we did a case where patient now has pain after RCT, during or after, which could be the flare up or normal pain. So these are both endodontic emergency we're talking about. Does anybody want to do this one? It's just like a public speaking session, I would say. Just practicing. I was speaking to one of the girls yesterday. She has never given exams. She has applied twice, and every time she lost money by canceling it because of anxiety. And now she's good. She has just 6 months remaining, and finally she's going to give exam. Highly anxious. So it happens. Why? Because we're looking for perfection. Remember, this exam is not about perfection. This is about you being okay with not being okay.
Dr. Nazia?
Yes.
Sorry, can I try again?
Let's do it, Anila. That's it. Like I'm
Okay.
saying, your growth is in your imperfections.
Yeah.
All right. Cluster two, diagnosis cluster. Okay. So this is about how would you manage an emergency patient. All right. So we're not expecting root canal in this patient. Clearly, you can see I'm leaving soon. All right.
Yeah.
Here we go. 3 minutes. All right. Ready, Anila?
Yeah.
All right. Here we go.
Hi, Mrs. Fitz. Thank you so much for visiting us today. I have just gone through a few of the history questions that you had answered already on the form. Is it okay if I ask you a few more questions just to know a bit more about the problem today?
All right. Okay.
So, you have mentioned that you have pain from a tooth. Can you explain a bit more about the pain?
Well, look, doctor, this pain is so extreme. I can't even tell you. Look, I haven't been able to sleep all night for the past few nights. I haven't been able to eat much because, this tooth, when the pain starts, it just goes on and on for a good amount of time, like 10 minutes or so, until I take painkillers and then it goes away. So I've got a flight to catch. I thought maybe I'll
Yeah.
just quickly check with you to see, if there's any way you can take this pain away, but I'll be back in 2 days.
Okay, so just a few more questions regarding this. You have mentioned that the pain stays around 10 minutes, you mentioned, right?
Yes.
Okay, so you feel like, does it go anywhere around, like towards the jaw, ears, or neck, or anywhere you feel?
No, no, it's like that entire area feels very sore and painful when it comes.
Okay. So, and how does this pain feel like? Like, does it feel like something is like throbbing in there or something else?
Yes, it's a very throbbing pain, doctor, when it starts, and it gets worse when I'm sleeping or lying down. It gets worse.
Oh,
So,
okay.
doctor, now given the time, they did mention you're quite busy as well. You're fully booked. Thank you so much for seeing me. So is there a way you could just take this pain away for me for now?
Sure, I will make sure that before you go today, we will do something about the pain. But I really need to make sure that we are on the right track. I can do things nicely for you. That's the reason I want to ask a bit more into detail so that we can focus on relieving the pain properly. Is that okay?
Okay, all right.
Okay. So if I ask you to rate this pain, I know you have already mentioned extreme, from 0 to 10, how would you give it the points, 10 being the most painful?
I would say 11
Oh, okay.
is very bad.
I'm sorry about that. Sorry to hear. Have you ever seen any or noticed any discharge coming near the tooth
No,
in the
no, not
gums?
at all. No.
Okay. And have you been feeling generally well? Any fever, any tiredness, or anything?
Um, no, I don't have. Remember, doctor, you did examine me. I don't have any of those issues. It's
Okay.
just extreme pain. And my biggest worry is what if it gets worse when I go away because I'm going for a conference. So, doctor,
Yeah.
do you reckon you could give me like Endorn? I was reading about it, how good that medication is.
Okay, so what we can do, because I'm just the look of your symptoms, it seems to be like this condition is inflammation of the pulp. Okay, yes, we do recommend endodontic treatment, which is called as RCT, root canal treatment. Have you heard about it before?
Yeah, I've heard about it.
Okay, so but that procedure is usually a multi-step process. It's not like it can't be completed in 15 to 20 minutes or in one visit. It's usually spread over a few visits. So what we can do is, considering also you are short on the time, you have to travel and we need to relieve the pain. I don't want to send you in pain at all. I just need to know a bit more about your medical history before we move towards the
My medical
treatment.
history is fine. It's good.
Okay, so no conditions. And what about do you smoke or do you drink
I
socially?
do. Yes, I do drink alcohol on the socially, yeah, but I don't smoke.
Okay, so how many drinks, if I may ask?
Depends, but mainly on the weekends. I don't drink during the weekday.
Okay, okay, all good then. So I will explain you some effects of the alcohol because, sorry. Okay,
Can
so
you
we
give me
come back.
endone, doctor? I'm looking for
Yeah,
painkillers. I'm worried about the pain. Why
okay.
is my tooth so painful?
Okay, so your tooth has inflammation inside the roots, which creates the pressure, and then sometimes this inflammation can go beyond the roots into the gum, into the surrounding neighboring tissues. That's why it feels more throbbing and painful. So what we can do today is we can provide you some active dental treatment by opening up the tooth, draining some of the infection, putting
Doctor,
some.
how long would it take for you to do that? Because I'm just mindful about your time and my time.
Okay, usually it's done within 30 minutes. Like sometimes it can take 15 to 20 minutes. But
Oh no,
because
I
you
can't.
have
I
so
can't do
much
that.
pain, you have so much pain. So the main concern would be to numb you first properly. If you are not numb, then we won't be able to proceed. So when you are
Yeah,
numb, when you are fully numb, then it shouldn't be painful for you to go through and it shouldn't take too much time
but then
because
again,
it's for
doctor,
your own good.
how long would it take for you to numb and to do the treatment?
Usually 15 to 20 minutes, but because you have intense pain. Have you gotten numb before with
I
any
think
other procedure?
I did, yeah, last time I did. But doctor, again, it's not possible. But I'm coming back after 2 days. You can definitely do that for me. For now, I'm concerned about this pain. How can you manage my pain?
So, if you don't want any treatment, what I can do is generally we recommend the treatment. What I can do is I can prescribe you some antibiotics to take with you, some painkillers. But let me tell you, because the tooth is dead, it does not have that much blood supply going through it. So, antibiotics won't be able to maybe comfort you 100%. You might get a flare up when you are over, when you have gone away, so it can happen. There are pros and cons to everything that we do. Okay, do you understand with me?
Yeah.
Okay, but yes, we can prescribe you some antibiotics and some painkillers.
So you're going to
And
give me
then
antibiotic. Which antibiotic, doctor?
I would, okay, so do you have any allergies to any medication or overall in general?
No.
Have you taken antibiotics before or
Um,
anything?
I mean, I've taken different antibiotics at different times for different reasons.
Okay, so what we can do is we can prescribe phenoxymethylpenicillin, which is one of the safest ones, with some. We can pair it up with with some Panadol or some ibuprofen, preferably ibuprofen because it's the inflammation in there. So that will be more relieving, more helpful for you. But again, I would suggest that it's better to have some active treatment done so that we know we have drained the infection physically. And after that, if needed, yes, we can add some medication for you.
Okay. All right. So,
And
and then which painkiller are you going to be giving it to me?
so you do you have blood pressure or any other thing? You mentioned you are generally fit, right?
I am fit and healthy.
Okay, then we can go with the ibuprofen because that usually works better in this condition. So you can take 400 milligram ibuprofen twice, two tablets, 3 to 4 times a day, depending on the severity of the condition, for a
Mhm.
few days, and then we review you back in 2 days.
Okay. And what would I expect in those 2 days when I come back?
Okay, so when you come back, we would be starting the proper root canal treatment. We would open up the tooth, drain the infection, put some
Is
antiseptic
this an
dressing
infection,
in.
doctor? Am I having an infection?
So usually the inflammation happens because of the bacteria staying in the roots. They create an infection because of which this inflammation process whole starts. So that's just
Okay.
another way to explain the inflammation. Sorry if I scared you with that.
All right. So there is an infection in my tooth. Okay.
Yeah. And once we have done it, so it depends again on the amount of the tooth structure left. So sometimes we can do a permanent filling on top if the excess is small, if there is not too much breakage. But everything we need to do an x-ray before we start so that we can do things properly, okay? And
Okay. So you're going to be
sometimes
doing it
we,
next time?
yeah, we would definitely do. I would prefer to do it today, actually, if we do any active dental treatment. Otherwise, yeah, definitely next time before
Okay.
we start.
All right. What else? Oh, time's up. All right, wonderful. See, good thing is, Anila, you're putting yourself out there and you're doing a role play. That's the main thing. And I just want you to be okay with just talking in front of people. That's the main thing, I
Yeah.
think, for me when we do these role plays. And what do you think about this patient? What was going on with this patient?
The patient was a bit stubborn, just wanted to get some medication, which is not good. Usually, active dental treatment is preferred. Patient needed some guidance, some oral health promotion regarding the effects of the medication. And I needed to explain a bit more on the alcohol for
Mhm.
oral health promotion, which I just blanked out.
Yes. Okay. Now this again, it was very good that we did. Now this is basically about a patient that comes with extreme pain. We're talking about extreme pain, and this was about um endodontic emergency. I think yesterday we did talk about it as well. So we spoke about these different endodontic emergencies that we see in our practices. So they are, you see, like they have different management. They don't fall into regular managements that we do. These are extreme pain. Now, whether it happens before we start the treatment, so this was the case about a hot pulp or acute acute irreversible pulpitis. It is a very painful condition. And there is this also chapter, so I'll upload this chapter as well from Cohen, taken references from this book as well, which is on the recommended book list. So do you see, there's a whole chapter called endodontic emergencies in Cohen. And with these emergencies, these patients come. Do you see pain? Do you see pain is both psychological and biological entity? Pain brings changes, in a patient, and also pain will impact the way you're going to be looking or treating these patients. Your local anesthesia will not work. So why are they giving us 2 days? Is because either way, hot pulp, you can't run it out. Sometimes, like we had that CPD webinar with Dr. Shekhar Badia, and he did talk about different strategies. How does he, settle hot pulp? A lot of times they have to give these patients painkiller for the treatment. They give them like painkillers 2 hours before or 3 hours before, let it work, and then they give local anesthesia. It doesn't work at all. Now, for this patient as well, local anesthesia will not work when you give it. So why we're doing so today, the whole idea is we explain to the patient why there is such extreme amount of pain, how we're going to manage this pain today, because this patient was going on a flight, it will make it worse. We're also tapping into a topic called, you know how people that go on a long flight or scuba diving, their pain gets worse. It's called barodontology. So when they go by a flight, there's increased pressure building on the plane as well, which makes this pain even more worse, right? So now in such cases of severe pain, what does Cohen says? So Cohen says that endodontic emergency are a special category and they require skill. That's the core sense of this case. So they are trying to say, how do we manage such patients? You have to, of course, talk about long term, but today we're tackling it with painkillers, removing the sources of pain, which is whatever is triggering the pain, and if possible, give them long acting anesthesia. That's it. That's pretty much you can do. So, emergency pain management. Now, phases of treatment. So, the diagnosis that we need to know is it just pain? Is there any swelling or not? So, that's where we go. So, we say when we start, that was a good start. Patient comes in pain. Make sure that you make them comfortable. It's all right, Fitz. So I do see that you were complaining about having pain from your tooth on the bottom right side. They love it when you look at top left side, bottom right side, upper left side. So this really gives them the attention of detail. So I did examine, yes, and I did notice a tooth that is broken that needs some treatment. And you're leaving as well, right? Patient says yes. Okay, so let's see what we can do, but would you mind walking me through your concerns so that I can help you in the best possible way? Do you see, I just quickly, in a summary, I tell them, okay, there's this tooth that is painful, and I know you're leaving, but let's go through your concerns, and I'm happy to help you. So this is like quick summary, 20 seconds. The examiner's like, okay, they read the scenario, they understand. Then move on. Patient says, oh, look, doctor, I've been having a lot of pain for the past few days. I couldn't sleep. And this pain was extremely worse. Now, what I did not give was exacerbating. I said I didn't sleep, but I didn't specify triggers for pain because there's a few different conditions we're dealing with, right? So when we talk about these terminologies or pain, it's hard. You cannot get inside the pulp. And the problem is whether it's acute or reversible pulpitis, whether it's necrotic, whether it's apical periodontitis, very fine differences between them, and management differs between each one of them. So that's why exacerbating becomes important. So it's all right. So you mentioned sleep makes it worse. So what else triggered this pain for you? Now, patient says in the exam very specifically, hot and sweet makes it worse. All right. And then we say, okay, And what else brings the pain? Because what is missing in this equation is cold. So I'm trying to, what else brings the pain? Patient says, I guess it's just these three. What about cold? I'm going to ask. Now, patient says, no, cold used to cause pain, but now it's starting to bring relief. Now, that's a big, very important information. So this is, look at how beautiful it is. So this is a pulp, and on the pulp, if you look at it, we've got the anatomy, the fibers. Now we have the amyelinated fiber, A fibers. These are the ones that are usually present in the upper part of the pulp, and we have the C fibers in the bottom part. Now, these ones, A fibers, are triggered by hot, sweet, cold, and pressure. All right, while C fibers only hot. And if a patient says, cold used to make it worse, and now it no longer causes pain, but I'm telling you that these fibers are dead. All right. Now the truth is not dead, because I can still experience hot and sweet. So that means the C are still there. Maybe the bacteria could be somewhere here, somewhere along the way, but it's not dead yet. So it's the late stages of acute irreversible pulpitis. That's the diagnosis. All right, based on hot, cold, sweet. They will ask you this question. So, doctor, is this infected? When you say this tooth has inflammation, they say, is it infection? We say no. Infection is when the tooth dies and the bacteria is feeding onto it. In your case, your tooth is not completely dead yet. Your body is still fighting hard, but yes, we're looking at the late stages of irreversible pulpitis because you're still experiencing pain with hot and sweat. So, but the most important thing is we need to treat this tooth because eventually once it dies, it will become problematic. Then patient says, well, okay, but doctor, how would you go about it? Remember how I said then, doctor, can you give me Indorn? So whenever a patient asks you a question, don't refuse, ask them, have you taken it before? Why do you need it? Right? Ask the patient. So well, certainly we can give you, always acknowledge. We say, certainly we can prescribe it for you if that's what you think. But how do you know this medication? I'm trying to rule out, am I dealing with drug seeker? How do you know this about this medication? How do you know this is going to help? And patient says, oh, I Googled and people were talking about it, how good it is. You say, yeah, it's a very strong painkiller. We give it an extreme amount of pain. But to give you this painkiller, we have to make sure there's nothing in your medical history that might interact with this medication. So would it be okay if I ask you a couple of questions? Now go back. Because oxycodone will interact with alcohol. Oxycodone will interact if they are taking any recreational drugs. And also, oxycodone is not the first line. NSAID is the first line. So paracetamol and NSAID are first line. So why shouldn't I give this patient NSAID and oxycodone? So then you double check. We say, all right, now, are you generally fit and healthy? Yes, I am. Okay, are you taking any medications, whether prescribed by your GP or over the counter? Remember, many patients, they don't count over the counter medication as a medication. So I wasn't doing this version, but other version patient says, oh yeah, doctor, I take cardia. Why do you take it? And patient says, it's a blood thinner that I'm taking it. Why was this patient taking a blood thinner? Smoking. That was the version. So, but I wasn't doing that version. So remember Elica's case? We spoke about it?
Yeah.
So Elica's case, we spoke about this patient started taking blood thinner to avoid stroke, but he didn't know that smoking was going to cause stroke. So in this case, patient was smoking, but taking a blood thinner, his friends were having stroke, patient was worried about stroke and started taking cardia, which is the low dose aspirin over the counter. GP doesn't know about it. All right. So that's again, I would double check with the patient. I say, all right, so you mentioned you're taking cardia. So why are you taking it? Patient said, oh, it's a blood thinner. I just wanted to avoid stroke. My friend died because of that. Oh, I'm so sorry to hear about that. Now, does your GP know about this, that you're taking this? No, my GP does not. Okay. Well, so what's a good idea? Whenever you're taking any medications, talk with your doctor about it. Whether it's something that you need it or not. But I'm happy to have a chat as well. Now, quickly checking any other um, uh, medications if you're taking. No. Okay, wonderful. Now, then I'll go back. So with this pain that you're experiencing, we call this as acute irreversible pulpitis, which sometimes, because of the severe amount of inflammation, these teeth are quite difficult to numb or treat. And oftentimes, when we do a nerve treatment on these teeth, you might still experience pain. So one option would be for us today, given that you're leaving, is that we manage it by giving some pain medications. So what I will do is if cardia is not there, then I'll say, I'll give you paracetamol take 1,000 milligram 4 to 6 hourly, and along with that, NSAIDs. If they're not taking, add it. Take 400 milligrams 6 to 8 hourly. And because I said 11 out of 10, oxycodone, you have to. This case is built on oxycodone. You are giving oxycodone to this patient. Now, whether you give paracetamol, NSAID, and oxycodone, or you give paracetamol and oxycodone, it's always there. All right. Now, should I give antibiotic? No. Even if it's late stage, this is assessment area. Now, when patient says, "Can you give me antibiotic?" Your question should be, why do you need it? Do you know why this patient wanted? Patient wanted to treat pain with antibiotic. So now we give antibiotic when the tooth is infected. This tooth was not infected. Now, the other way to manage pain was non-pharmacological. So patient said cold was making it better. Fine. Drink cold waters, have more good. At nighttime, keep your pillow high. So managing the pain non-pharmaceutically, I'm talking about next 2 days. And now that the patient was going on a flight, I would give local anesthesia, a block at the back. You can use Articaine. So we can use Articaine. So we say now also, given that we don't have enough time to treat this too, so if you would allow me, I'll give you an injection right at the back of your mouth. And that should give you a few hours of pain-free period, especially going on a flight, will increase your pain. But make sure that you don't bite on anything because your tongue will also be numb. And when you come back, we'll book you in and we'll do the treatment. Should I be talking about pulpotomy in this case? Well, one of the options that we give, if you have time, is temporizing the tooth. So I'm going to go back to Cohen. So Cohen talks about temporizing the tooth. Now, if you acute irreversible pulpitis, if you just put a filling on top, it will lead to, remember, amalgam filling done by a colleague. What did your colleague do? Your colleague also placed a filling on a tooth that had irreversible pulpitis and it led to liquefaction necrosis. So if you are covering it, go with pulpotomy. Otherwise, I'll just send this patient. Any question? No question? All right. So remember, this case is management of acute, very painful, irreversible pulpitis. Do you know this case is very similar to the other case? I'll tell you. They are very smart. We have this case cellulitis in orange set. Let me open it up. Cluster 3, which now is coming with pericoronitis. Now, in this case, if you think about it, we had a tooth, 2-8, wisdom tooth, and now they give us a lower tooth. And they give you this swelling on the face, they give you swollen lymph nodes, and they're also telling you that you need to refer this patient to a specialist, right? To be honest, you would not be able to remove that tooth, neither a specialist, because mouth opening was limited. You needed that 3 days to begin with. So for those 3 days, we were giving them antibiotics. And my antibiotic would improve the mouth opening in 3 days. Once the specialist see, the tooth will be removed. Now, in this case, I cannot numb the tooth. It's a hot pop. So giving this patient painkiller for the next 2 or 3 days, especially with anti-inflammatory, once the patient comes back, you can numb it up and treat it. That's what it is. All right.
Dr. Nazia, just a question about oxycodone. So will that make the patient drowsy, especially that he's traveling soon? So will that add to it?
Yes, so we always give them instruction. Remember, you're supposed to be giving them painkillers, right?
Yeah.
But you also have to give them instructions. So the main instructions we give them is only take it at nighttime. During the day, take paracetamol 4 hourly because paracetamol they can't take it more than 4 times in a day. So what
Okay.
are they going to do at nighttime? So during the day, paracetamol 4 hourly, ibuprofen 6 hourly, and at nighttime, take 1 tablet of oxycodone for 3 days. That's it. That we're prescribing. Why not to take it during the day? Because it can make you drowsy, you cannot focus, and also special instructions to avoid taking alcohol with that. That's it.
Okay. So won't it have any after effect during the day? Like if even if he's taking at night, will it have any prolonged effect when he wakes up?
No, not really.
Okay.
The effect of oxycodone is 4 to 6 hourly. That's what how much we give to the patient, right?
Okay. Okay. All good. And if he's a regular drinker, like in this case, you mentioned he's just a occasional drinker, but if he drinks on a daily basis, then we just give preventative advice on that, right? If at all we are prescribing oxycodone.
I did mention that I'm going on a weekend and it was a weekend, right? I drink on the weekend.
Yeah, yeah.
So warn me. We say, look, I know you mentioned about you drink mainly on the weekend. Now with this medication, please make sure you don't take alcohol because the two of them can impact your brain and it will compromise your breathing. Just warn them. Just give them instructions. Don't do it.
Okay, all good. Thank you.
Sorry, doctor. So the ideal treatment in this case would be doing like pulp extirpation or at least pulpotomy, if I'm not wrong. If the patient says, as you were saying, like, oh, we don't have time, we like, no, there's no time, refusing, we can just do an LA block or and prescribe the medication. Is that right? But the idea would be to do at least some extirpation or phlebotomy. Is that right? Or
It would be nice to do that, but you can't. Now remember, we have that quick set Mrs. Loe's case. Now clearly mentioned short term and long term, right? They mentioned and we spoke about it. Now in this case, they said emergency and definitive, right? So they are looking at everybody knows about definitive RCT. We've got so many cases, phlebotomies. We've all done that. They know it, you know it. But many candidates struggle with emergency because now in emergency you have to give this patient oxycodone, and we're too afraid to give oxycodone. That's why it becomes difficult.
yeah, especially if they talk about endome, that they are aware about this medication, you get a bit concerned about prescribing oxycodone, right?
Yeah, so but then you ask them, so sometimes they say endone, sometimes they say, oh, my wife takes codeine. Can I take codeine? Codeine definitely not. It doesn't work.
Yeah.
Just educate the patient, but you are supposed to be giving oxycodone.
Okay, so if the patient agrees to go ahead with some pulp treatment, we do and temporize and just give
Patient
some.
will
Oh,
not do it.
oh, okay. So in this scenario, there's no way you can do any like.
They will
Oh,
clear. So they say you are fully booked, and the patient is also very busy.
okay.
Patient is
So it's
leaving.
always a no. Okay, it's always a no. So we just need to prescribe medication and hope for the patient to come back in actually 2 days, right?
Yes. And just to make matter worse, they've added these pressure difference, right? So they give us different versions. So sometimes they say, oh, I'm going to Brisbane, Darwin, Perth, Sydney on a flight. This is what I want you to warn the patient. And there's very interesting facts here. They say that normally there are changes in pressure when we go on a flight, and that's what leads to sudden pain in the tooth. Now, the type of pain will depend on the part. If you look at it, pulpitis, they feel extreme amount of pain during either takeoff or when they're coming down, right? Not during it, but when they go up or when they come down. So that's what I'm going to warn the patient about it. So they should know and it's educating them. There's another version where this patient was going on a camping trip fishing. Are they going into the sea? So then again, it becomes problematic for us, right? Warn them. So a hot pump that has got so much pressure inside it. Now we're expecting, you're educating the patient that how important it is. So do you see suspected periodontalgia, as they say that yes, pulp testing when you do it, you see that then you need to see that this patient had a caries. You see that. What was here? I think there was one thing very interesting. Most patients with clinically manifest had carious lesions. This patient had or defective restoration extending into the dentine. Now, what causes it? So it occurs when the trapped air inside a tooth expands during low pressure conditions, and this puts pressure on the nerves. So that's what I'm explaining to the patient. I said, look, we cannot treat this tooth today, given that you don't have time. I'm fully booked as well, but at the same time, I understand that you're going on a flight. Now, do you have any idea how this pain can intensify on a flight? Do you know how flights can? Patient says no. Well, when your plane takes off, there's pressure that builds up. Now, there's already a lot of pressure inside your tooth, and so this pain will intensify, and which is something I don't want you to experience. So then go through the options. So let's manage it by giving you painkillers. All right?
So, Dr. Nazia,
Yes.
we are not at all talking about the pulp extraction or like anything like pulpotomy in this case. We are not talking.
You're talking it as part of when they come back. Remember, it goes into
Okay.
definitive management. So diagnose emergency today, painkiller, non-pharmaceutical, or maybe local anesthesia. And then we say, when you come back, we will book you in, and then we can start the root canal treatment.
Okay.
And taking these painkillers for 3 days will also settle the tooth, the pressure, reduce the inflammation. So it would be easier for us to numb this tooth.
But when they like come back, then we have to give them the definitive management, not the emergency one, right?
So yeah, definitive is either complete pulp extirpation. Sometimes we do pulpotomy as well, but both comes under definitive. So this is from
Okay.
Walton. Walton says that here, even in cases of a severely painful pulpitis, local anesthesia can be administered so patient can completely discuss his or her diagnosis. Informed consent. What is it? It says include options for no treatment, risk and benefit. And then I think here was somewhere about the treatment options. Was it here? Oh, here. You see, definite treatment accompanies any provision for emergency, neither a pulpotomy nor a pulpectomy, nor a placement of any temporary restorative material is expected to last long term. And patient expectation should be set appropriately. So, pursuit of definitive treatment should involve options for non-surgical root canal retreatment or extraction. That's what we're talking about.
Okay. So we are talking about doing RCT when they come back.
Yes, we say we'll book you in and we'll start the first phase of the root canal treatment. And taking these medication means local anesthesia will be more effective.
I'm asking about are we talking about pulpotomy here or not? Because it's a case of irreversible pulpitis, and that's what I'm asking.
Okay, so pulpotomy, now again, I'm going to go back to how effective both treatments are. And there's a lot of research that is done. So this was a study that was done. Now, this tooth had irreversible pulpitis, both. Now, one option is we remove only pulp from the coronal chamber. And in this patient, it wouldn't be a good idea because this patient cold was starting to make it better. That means the bacteria has entered the radicular chamber, right? So there's two parts of the pulp, coronal, radicular. So, but when they did a study, they said the results are the same. Even in irreversible pulpitis, pulpotomy does give similar as long as you have a good seal. But ideally, if you remove it all, it's better.
Yeah.
So just go with, don't talk about pulpotomy, just go with the complete root canal.
Okay. Okay.
If I have an option today, if patient would allow me, I will do pulpotomy because it's already an open cavity, right? Do not put a filling on the tooth. Okay.
Let's say patient is like convinced, but in the scenario, there is this thing that we can't do it today. We are fully booked. So are we convincing him or not?
Okay, so you are fully booked?
Yeah.
Okay,
So if we are not convincing him like at all, just I
okay,
want to know.
let me explain you this and I'll come back to that question as well. Okay, so this is, now remember, when a patient has irreversible pulpitis, now normally these teeth will have necrosis a bit later, not straight away. You know, it takes a while as long as it's open. Now they say that when you close a tooth, you seal it, that inflamed pulp with a filling, it leads to necrosis quicker, faster. All right. So, which is the case here? So, we have a tooth that has an open chamber cavity. This part is already open. So, if let's say this patient is not in a rush, but I'm fully booked, I'll say to the patient that one option is that the tooth is open already. I can either check with my patient if they're happy to wait, or I'll check with my colleagues to see if they can just, remove this top part of the pulp and place a medicament inside it. If you are going pulpotomy, this has to be removed, and odontopist should sit here. Otherwise, just putting a filling is not a good idea.
Yeah.
Does it make sense? But it's just not possible for this patient.
Okay.
Yeah, that's what your colleague did. Remember that amalgam filling done by a colleague? That's what happened in that case.
Dr. Nazia,
Yeah.
can't we like say that I'll ask one of my colleague to adjust, like if the patient wants some treatment today, or if the patient can manage some time today, then isn't it better to do pulp extirpation as compared to just giving painkillers?
Now, do you see, look, I hear you, like what you're saying, but do you see, this is where ADC is testing you guys, and we're all getting very uncomfortable with that. Look, we already have a case, consent surrender, red cell, right? Where this entire case is built on root canal, and we're talking about it, we're all happy with it. We've got many other cases, but this is just one case where they've blocked you away. They're saying, don't talk about root canal. You cannot do it. Now, in real practice as well, forget about this case. In real practice, you will see these patients in real life that comes with extreme pain. I mean, I went on a trip during my holidays, and on that trip, I met a lady that had hot pulp. And on that trip, there's nothing I could do. I just told her the same thing. I gave her the exact same strategies. I said, do this, take these painkillers in this way. And the next day, she called me up. She's like, the pain is gone. Right? So that's what they're trying to teach you. How would you manage? Let's say you're stuck in a place, you cannot do a treatment. Is there any other way you can help these patients? That's why there are these chapters called Management of Endodontic Emergencies. Does it make sense?
Yeah, I get that. If I don't have any option, like if I don't have a dental setup, then obviously I'll prescribe painkillers. But I'm asking if it can be managed today. Suppose one of my colleague has some free time, and because
But
I'm
then you're
asking
putting a
this.
pressure on your colleague.
No, I'm asking this because, like in your notes, it was written that you can ask your colleague, or you can like give the option of extraction. That is where my confusion is coming from. Like, I want to know, like, what do we do about these things?
Yes, you see, with those cases we tried, but the examiners were blocking our way. So when they say you're fully booked, that's what when we said to the examiner, look, I'll check with my colleague. They said everybody's booked. You're the only one that gave me an appointment. Then we say, oh, where are you going? Let me find your dentist. Why don't you go see there? Patient said, no, I'm finishing conference 7 p.m. There's nobody open. Right? So they're blocking you away. They're saying, don't bring that in. So over a period of time, we started to chuck it away. We were like, okay, forget about it. All right? So it's about you.
Okay, I get it now.
Dr. NTG says in severe acute pain, we can give the patient 3 like medication, paracetamol, NSAIDs, and oxycodone at the same time. In this case, can we do that?
Yeah, that's what we're doing. So the only times you will combine 3, let's say the patient is not taking any cardiac. Okay, so I'm just going back. So this patient, when you get a version, which the version I was doing, double check. This is also coming in the exam. So we say, okay, well, what painkillers did you take? Patient says, I took paracetamol. Okay, did you take any other painkillers? No. Is there anything in your medical history that I should be aware? Are you taking any medications over the counter? And if a patient says, yes, I'm taking cardiac, now this is an aspirin. You cannot combine NSAIDs with aspirin. So in that version, just paracetamol and oxycodone. But if they are not taking cardiac, then it's paracetamol, NSAID, and oxycodone.
Thank you, doctor.
Dr. Nazia,
Yes.
if we suspect that the patient is addict to that drug, oxycodone, then what should be our response to that? Are we giving him or not?
How would you know patient is addicted? It's a drug
Like
seeker.
she knows everything about the drug. That's what TG
Yes.
said. Yeah.
Yeah, so there's a difference between drug addict and normal patients. So there are patients that do a very good research. They have done their homework, they know all about it. It doesn't mean they're drug addict. Now, the main difference would be, now with drug addict, when you give them alternative options, they will not agree. But normal patient will agree. That's the only way you would know. Drug addicts, they want a specific brand, a specific dose. No matter what reasoning you give, they will not negotiate with you. But a normal patient, when you convince them, they're like, fine.
Okay, so in this case, we are giving oxycodone, right?
We are. This is not a drug addict.
Yeah. Okay.
This is about emergency pain management. So this case doesn't come very often now, unless it's a pink set. It used to come a lot. So again, the main thing was they say, like this girl, she got this. I'm leaving now for Brisbane and I'm having pain. And patient said, I'm coming back in 2 days. Mostly patient says I come back in 2 days. So in 2 days, it's acute irreversible pulpitis. You will not give any antibiotic. So this case and that apical 1/3 group broken in the red set. I mean, there's been some changes in that case now. But generally in these 2 cases, we were avoiding giving antibiotics. We were educating the patient that antibiotic is not needed. So patient said hot makes it worse and it lasts for a minute. There was no pain on biting. She took Panadol. It does make it a bit better. Medical history was clear. And patient said, how should I take paracetamol and ibuprofen? So they wanted, in this case, they're testing your chapter. Have you read that chapter in TG? How to manage pain. How should these painkillers be taken? So like in odontogenic infection section, do you see like how they've made an OSCE out of each section? So same thing in this case, they're checking, do you know pain management? It was, I think, yeah, orofacial pain. Acute and post-procedure pain. So they're checking, do you know how to manage this pain properly in these patients? So this was our patient, irreversible pulpitis. Advise the patient to avoid food or drinks that provoke. So avoid hot, sweet, take cold. Offer analgesics. Do you see? NSAIDs are preferred. This will improve the hot burn, reduce. Cover any obvious cavity. So don't do it. Don't put chewing gum. This is for GP. I don't have time for pulpotomy. This examiner said. He said, I don't want to do it. People start talking about pulpotomy, so don't even get into that. Patient said, don't even talk about extraction. They're not interested. And patient said, can this turn into infection? If yes, how long will it take? So this is a normal patient with normal health. So as long as the cavity is open, I don't expect this to die in the next 2 days or get infected. But yes, if you do cover it, it becomes problematic. So that's why no need. So patient said, now sometimes they say I'm leaving in 6 minutes, 10 minutes, 20 minutes, 5 minutes. And this other patient, the examiner said, I'm going to Darwin, staying for 5 days. And I took Panadol 6 hourly. So in this, pay attention to what they're saying. If Panadol 6 hourly, make it 4. I wanted to know how medications would work. And then patient said, hot was making it worse. Why hot makes it worse? Why cold makes it better? This is a very important. So this case and fluorosis, they're interested in pathophysiology because your management is dependent on that. So the main thing was the nerve. So again, very simple. Just say that because this tooth was not treated and the bacteria are still irritating your nerves, and your body is trying to get rid of that these bacteria by pumping a lot of blood. There's a lot of pressure. Some of the nerves that were sensitive to cold have started to die, which is why cold no longer makes it worse. And when you take cold, it reduces the pressure inside the tooth. Patient said, Doctor, can you give me codeine? My wife takes codeine and she said it's really good for her joints. Can I try this? So codeine definitely is not good. It's not good for dental pain. It works the same way as paracetamol. Patient was not ready to listen about any treatment, pulpotomy, pulpectomy at all. Patient was only interested in painkiller and said, I have to go and I want painkiller. I don't want to listen about anything else. Do you see that this is how the examiners are? And they were all, with every candidate, they keep asking, give me antibiotic. Remember, when you ask them, they say, I want it for pain. And do you think that the tooth can die in 2 days? And again, patient was not taking painkillers properly, like Panadol. You'll see all of these cases, Interstate, none of them, they took NSAIDs. And NSAID is what this patient needed, along with oxycodone at night. But NSAID is what's going to settle that inflammation. NSAID is the treatment drug, the choice for hot pulp, which is what they want us to talk about. Then what else was here? We can go through. This patient was going to Melbourne for official trip again, only took Panadol alone. So why should I mean, yeah, this patient was also asking about pain scale. Oh, do you scale pain? How? How many scales are there? Mr. Patrick was there. Oh, same thing, only took paracetamol. Yeah. So do you see the pattern that I'm talking about? All versions, only taking Panadol, coming with extreme pain, expecting antibiotic would settle the pain, but we say no antibiotic, I'm going to give you NSAID with oxycodone at night time. Other than that, just make sure, try other alternative. If it gets worse, I'll see you in 2 days. We'll book you in and we'll do start the root canal. And then focus on why it took you so long? Why didn't you come earlier? And that's preventive advice. Done? Any other question?
Yeah,
So
Dr. Nazia. Yeah.
Yes.
the
Sorry, go ahead.
LD you are providing today, is it Articaine or should we go for something for a longer duration?
Oh, no, don't give longer duration. Articaine is good. Remember, it's going to longer duration. We give it for neuropathic pain. This patient was going on a flight. So Articaine is good, temporary. This is given by Dr. Ravona. She's an ADC examiner. And it's given in TG as well, so it should be fine. So here it says administration of a dental block may be effective for initial management of severe pain before follow-ups. So Articaine is good. Yes.
In this OSCE, the health promotion part is basically related to antibiotics and painkiller, right? Or any other thing also we have to look upon.
No, antibiotic and painkillers, these are management. Health promotion is around attendance. Why did this patient end up with caries? Do you see? Like, look at the story. It says here, patient comes with a broken tooth, right? So what was going on with that tooth? Did this tooth had a filling? Why did this filling fail? And do you know when the filling failed? Patient was drinking alcohol or smoking, some versions, right? Oral hygiene, attendance, smoking, alcohol, these are all health promo. There was another case. She said she's a busy businesswoman and don't have time to see a dentist. Attendance is the problem. The last time she saw a dentist was 4 years ago. All right, so that's where the problem comes in this case. All right, so just the importance of, right now it's not infection, but if we keep delaying it, she's going to lose this tooth. And again, sometimes infection can be life-threatening. All right, what else?
Hi, Dr. Nazia.
Yes.
May I ask for painkillers, how many days do we prescribe? Only for 2 days or 3 days, 5 days?
Oh, very good question. And that's also important assessment area. Now they want to know how they should take these painkillers and how will you step back. Remember, there's a strategy that we go with step back. So I'll take you to medications. Where is it? So there's a section that we have in TG, I don't know where it is, where they talk about which one should they stop first. So remember, if they're taking paracetamol, NSAID, and oxycodone, so we'll stop oxycodone first. Then the next one you need to stop is NSAID, and the last one is paracetamol. All right. And I'm just trying to see, it's given in TG about painkillers. Oh, where did I save it? It was beautifully explained about which one they should take regularly and stepping back. Or official pain. Let me see if I saved it here. Yeah, acute pain. I think it's here. They want to know about the pain management stepping back. I don't have it here. Yep, there we go. This one. So this is TG. So it says to optimize pain management and minimize harm. So prescribe both NSAID and with paracetamol regularly initially. So for the first 2 days, I want you to take paracetamol and NSAIDs, ibuprofen, 4 to 6 hours. All right. And then as you start to see improvement in pain, you only take NSAID when it gets worse, but paracetamol regularly. Do you see? So one, they only take it when it starts to settle and then start leaving the other one. Okay, so that's how we go. So it's given in TG how these painkillers should be taken. So
Yes, thank you, Dr. Nazia, for this explanation. The reason why I'm asking is this patient, for this particular patient, is saying that he's traveling for 2 days over state. So if we book that, let's say if we give the earliest booking that we can give her for her definite treatment. So should we prescribe painkiller for longer than that?
No, 5.
Only 5. So if we book like 2 days, after 2 days, if she's back and we will give her treatment, we still prescribe for 5 days.
Yeah, so normally we say that take these painkillers for no more than 5 days. But if the pain settles, you can cut it down sooner as well. But maximum is 5. It's like antibiotics now that we give. And oxycodone, remember, is 3 days, no more than that.
Okay, I see. Thank you very much.
Right. So it's just we don't want them to be relying on painkillers forever. We want these patients to come back for an active treatment. Right now, there's a valid reason, but generally, they need a treatment. All right. Any other question?
Sorry, Dr. Nazia.
Yes.
I have a question. Could we give articaine for block, or should we give a lignocaine for block?
Oh, these days we're giving articaine for block. New TG.
Okay.
Yeah, I mean, that's what Dr. Shekhar Bhatia was also talking about it. Yes, there has been small number of cases of nerve damage, but generally it works really well. Articaine works really, really amazing, especially in hot pulp.
Sure, thank you.
All right. So just going back, this case, if you think about interstate, I want you to think about hot pulp, a very extreme kind of acute irreversible pulpitis. Patient comes and probably we're looking at the late stages. And with such a patient that is going on a flight, coming back in 2 days, the focus is we explain to the patient why they're having pain. And then also, how can we manage this pain today on an emergency basis? Because regardless, hot pulp, if you treat them as well, they lead to flare up as well. So it's always a good idea to calm down the pulp. And the way we would calm down is, patient is all version was taking paracetamol. We're adding ibuprofen unless there's cardiac. But because these two alone in severe pain wouldn't work, the patient cannot cross that 4 gram. So we're adding oxycodone only for nighttime and maximum 3 days. In 3 days, when the patient comes, we start with pulp extirpation, and then with that, hopefully we're not going to get end up with flare-ups, because flare-ups can happen during the treatment as well. So this is going to prevent that flare-up. But the question here is, where were you all this time? Now, patient thinks that antibiotic will settle the pain, but we're saying to the patient, no, this settles the pain. You need something anti-inflammatory. Antibiotics given when there's an infection. You don't have any infection. So that's the entire discussion about this case. Simple, right? Easy. So this is how the OSCEs work. So when you look at from this perspective, now you no longer have to memorize it. You cannot memorize these cases. Believe me, once you do, I would recommend you guys to do on-site mock. Don't ever go into the exam without a mock, especially if it's your first attempt, because in the exam, it's going to be a different experience otherwise. That's about it, I guess. So we're going to be the way. I'm going to see you guys tonight, and we'll talk about some changes that I've spoken to candidates about. And then don't worry about it. Let's say if there was any need, any cases that like pericarditis, if you feel like we can always do a role play for that as well, and I can show you how it is usually done for those cases that have changed a lot. But flabby ridge, we're covering next week. Green set and red set that we're covering the next 2 weeks. These two has massive changes in the exam. So, all right. No worries. Thank you so much, everyone.